Good morning, everyone, and welcome. I'm Cindy Friedman. I'm the Senate Chair of the Joint Committee on Healthcare Financing. On behalf of Chairwoman Benson and myself, I'd like to welcome you to the committee's 5th legislative hearing. Chair Benson will be joining us shortly. At today's hearing, the committee will hear testimony on proposed legislation related to systems of integrated healthcare financing. Before we begin, I'd like to have the members present go around and introduce themselves, starting with Rep. Hunt.
Aria Chandler, 1st Worcester District.
Natalie Higgins, 4th Worcester District.
Christine Barber, Somerville and Medford.
Thank you and welcome to the members. Before we begin, we're going to do a little housekeeping. The first thing I want to remind the members of the committee is after you're done speaking, please turn your microphone off. We can only have 3 on at a time, so it would be best if you spoke and then turned it off. I want to briefly describe the process today. So first of all, we're going to hear from people mostly in the order that they signed up, with the exception of legislators who we will take out of order due to a number of conflicts going on in the building at the same time. I ask everybody to kindly refrain from clapping, hooting, whistling, booing, hissing, and to refrain from placards and signs. We want this to be an open but very respectful hearing where everybody feels like they can come and say what they need to say. I require everybody to turn off their cell phones, okay? Just turn them off. And if I keep hearing them, we're going to ask you to leave or go outside because it's very, very distracting to both the testifiers and the people up here. Please indicate when you come up the number of the bill and the name of the bill that you're testifying on. We're going to have a 3-minute limit per person, and if you are a panel of 3 or more, you will get 9 minutes for the total panel. And we're going to ask you to keep to that so that people who are waiting and are farther along in the line get their chance to speak. I think that is the, one other thing. We read all the testimony that is given to us. We promise we read all the testimony. We assure you we read all the testimony. So if you have written testimony, we ask that you don't read that when you come up. It will probably take longer than you want it to, and it will be redundant. So we're just asking people who want to come up and testify, if they have given us written testimony, please don't read it. Just, tell us your story. And you're also welcome to get up and say, I'm here to testify, and I want to agree with everything the person before me said. So thank you. So your presence here is welcome. Just showing up means you care. And if you don't read your testimony, it will expedite the process. So, okay, having said that, I think we are ready to begin. And the first person is Suzanne Curry and Dan McHale.
Is this working? Yep, okay, good. Good morning. Good morning, Chairwoman Friedman and members of the committee. Thank you for the opportunity to testify today in support of House Bill 1126. Great. An act to ensure affordable health connector coverage. My name is Suzanne Curry, and I'm a co-director of policy and government relations at Healthcare for All. We can be proud that several iterations of state healthcare reforms have led to 97% of Massachusetts residents having health insurance, although we know there is more work to do. One of the programs that has led to this success is the Connector Care program, formerly Commonwealth Care. Using a combination of federal and state funding, the Connector Care program provides subsidized health insurance coverage to individuals with incomes up to 300% of the federal poverty level, which is about $38,000 a year in income, who are not eligible for Mass Health and don't have an affordable offer of employer-sponsored insurance. In the face of ongoing federal threats to the Affordable Care Act and the state reforms we've built up here in Massachusetts, in anticipation of any local market changes, this legislation is meant to strengthen state-level protections for the coverage expansions that we've built over the 13-plus years since Chapter 58. In particular, this bill does three things. First, it codifies the current practices and policies of the Health Connector to offer affordable plans to the lowest income residents, specifically offering two $0 premium plans to people who are under the poverty level enrolled in Connector Care, and at least one $0 premium plan to those up to 150% of the federal poverty level. For context, that is about $12,000 a year in income for under poverty level and about $19,000 in income, 150% of federal poverty level. These are some of the protections that had been part of the state law before the state implemented the Affordable Care Act. And for context, in addition, no one below 150% of federal poverty level pays any premiums in the Mass Health program. This bill also brings additional transparency to the Commonwealth Care Trust Fund, which funds the Connector Care program, by doing two things. It requires an at least annual accounting of the inflows and outflows, the revenues and the expenditures in and out of the Commonwealth Care Trust Fund to be reported to the Health Connector Board to give policymakers the information they need to make decisions about creating the coverage program year after year that is right for our consumers. And it also requires that a sufficient amount of funding is in the Commonwealth Care Trust Fund to ensure that the Connector Care program remains whole and we can continue to offer as affordable coverage as we do today in the future. Last, this bill gives the Health Connector tools it needs to get more plans to participate in the Connector Care program, especially in areas of the state where there might only be one plan available, and there is concern that in the future with local market changes, there may be no plans available. So this gives the Health Connector, in consultation with the Division of Insurance, additional tools to require more plans to participate. Is that no? Okay. So Connector Care essentially plays an important role in maintaining the high rate of coverage in Massachusetts. And in a high-cost state like Massachusetts, many low and moderate income individuals are struggling to make ends meet, and we want to make sure that the Connector Care program is available for them. We believe that this legislation adds important protections into state law that will help maintain the program over time. And thus, we asked the committee to please consider a favorable report for House Bill 1126. Thank you again for the opportunity to testify.
Good morning, Senator Freeman, members of the committee. My name is Daniel McHale. I'm the Senior Director of State Government Finance and Policy at the Massachusetts Health and Hospital Association. I'm pleased to join Healthcare for All and the ACT Coalition to voice strong support for House Bill 1126. MHA has been a strong supporter of the coverage expansions over the many years in the Commonwealth, and we're proud to be one of the founding members of the ACT Coalition. Now, much of the Commonwealth's current focus in healthcare, including that of state government, healthcare providers, insurers, is controlling the cost trend and improving quality. And this has been accomplished through various innovations, creations of ACOs, risk sharing between providers and insurers, increased provider accountability for the health of patients beyond the walls of their facilities and their offices. And this is deservedly where the focus should be right now. But this is only possible because we have near universal coverage. Without that foundation, it would be immensely challenging to manage a patient community if a sizable portion of it was uninsured. And that is why it is imperative to always maintain a priority on protecting the coverage expansions that we have made as a Commonwealth. And this is the goal of House Bill 1126. As my colleague from Healthcare for All has explained, this legislation will effectively reestablish a protection that was part of the 2006 healthcare reform law for those people who receive insurance in the Connector and have incomes below the poverty line. And with the implementation of the Affordable Care Act in 2014, this protection unfortunately got lost in the shuffle with the retirement of the Commonwealth Care Statute. Fortunately, the successor program, the Connector Care, has maintained the same goals of affordability, and we appreciate the legislature's and the Baker administration's commitment to these state subsidies. However, we believe the protection for the lowest level of income, those below the poverty level, should not be subject to an annual decision-making process by the Connector Board. It should be a protection that is afforded in state statute, just as it had been done under Chapter 58 of the Acts of 2006. Supporting 2 zero-premium health plan choices for the low-income group provides the appropriate balance of health plan competition, consumer choice, and stability in the provider and health plan management of patient care. For each year, Connected Care plans effectively bid on the premium levels in the connector. Therefore, the lowest cost plan can vary each single year. Now, if the connector only allows one zero premium plan, which it has in previous years, then the enrollee needs to switch plans if they cannot afford the current one. Patients switching plans every single year, and even some cases providers, due to health plan network differences, conflicts with the very approach we have all endorsed to improve care management. Now, other aspects of House Bill 1126 provide greater transparency and protections on the funding for the state subsidies that make the insurance in the connector affordable. Now, while the Commonwealth has remained strongly committed to these subsidies, the Commonwealth Care Trust Fund has unfortunately not been as transparent as it could be. For the connector population, this trust fund is critical to maintaining affordable coverage and increased transparency on the funding available to support state subsidies. And that transparency is an important ingredient in that protection. So we thank you for your consideration of these concepts included in the bill. We believe the Commonwealth's goal of maintaining coverage gains and succeed in the next phase of healthcare reform would be supported by this bill. So we thank you for your time. Happy to take any questions.
Thank you. Are there any questions from?
Thank you for your testimony. Can you talk briefly about if this bill would be helpful with some of the federal changes federal changes that could be coming down the pike?
Well, I think one of the things that it does is it does make sure that there's something in state statute that requires affordable health plans available to the lowest income enrolled in the Health Connector. So it depends on what the changes are that may come on the federal level, but we think having these state level protections might mitigate some of the federal changes that are coming. We still have to see what happens with the federal lawsuit around the invalidation of the Affordable Care Act, which would impact Massachusetts and the funding that we receive. We think putting these protections in place would at least put protections in for the lowest income to be able to continue to afford plans through the Health Connector, but we'd have to take a look at what other changes are afoot to see what the impact would be. Do you want to add?
Sure. I would just add on the transparency and with the trust fund, the funding is how the connector would have to make decisions on changes if the federal government were to change its commitment to the state. And so just having transparency for everyone to understand, what level of funding is available to support subsidies in the absence of federal funding or reduction, that would be helpful.
Any other questions? Okay. Thank you very much.
Thank you.
And we've been joined by Rep. Ultrino. Welcome. And we've been joined by our co-chair.
2.5 hours.
Yeah, it's okay. We started late. We'd like to acknowledge the Massachusetts Bay Transportation and the Mass Pike, and thank you to all those who braved getting into the State House. We won't talk about whether we need more funding for the T. That's for another group. Okay, I would now like to ask, that's what I'm doing, Senator Eldridge, and I think Rep. Sabato and Rep. Garlick, and the crew.
Good morning. Chairwoman Friedman, Chairwoman Benson, members of the Joint Committee on Healthcare Financing, thank you so much for taking us out of turn. We are here to stand in support for Senate 683, House 1194, an act establishing Medicare for all in Massachusetts. This is the earliest that the Joint Committee has held a hearing on making healthcare right in Massachusetts, so we want to express our deep appreciation to the chairs. The legislation I'm very proud to file with Representative Denise Garlick and Representative Lindsay Sabadosa. An act establishing Medicare for all in Massachusetts would declare that it is the policy of the Commonwealth to provide equitable access to quality, affordable health care services for all of its residents as a right, responsive to the needs of the Commonwealth and its residents without co-payments, co-insurance, or deductibles. The bill would create the Massachusetts Healthcare Trust, guaranteeing to pay for all medically appropriate health services, funding capital investments to make sure that every part of Massachusetts has adequate health care for its residents. It would include dental care, end-of-life care, and everything else we need to make sure that everyone has a dignified life from cradle to grave. If I were to compare it, Madam Chairwoman, to an issue to a value, I see it as public education. Is wherever you grow up in Massachusetts, you have a right to an education, you have a free education. We're really looking to make healthcare right along that same sort of model. How do we pay for it? Like any universal good, universal value, we would need to raise taxes to pay for it. It would include an employer payroll tax of 7.5%, exempting the first $30,000 of payroll per business, an additional 44% payroll tax on establishments with 100 or more employees, an employee payroll tax of 2.5%, a 10% payroll tax on the self-employed, and a 10% tax on unearned income. The bill would also include a workforce training fund, recognizing that more likely than not, health insurance companies would go away, and we would need to find a way to retrain those employees. So there's a national conversation on healthcare. We want to make sure there's a state conversation on healthcare. I want to offer a brief personal story, is that although I was always for single payer, making healthcare right, 10 years ago this fall, I suffered a major seizure. Was in both Mass General Hospital and Spaulding Rehab for a total of 6 weeks. Had a major spinal cord injury as well as dislocated my shoulder. Beyond all the costs to be in the hospitals, it took me approximately 3 years to pay off those medical bills. I am very grateful to have quality health insurance like all legislators have. I'm very grateful to have a middle-class salary, but it took me 3 years to pay the medical bills, not only being in 2 separate hospitals for 6 weeks, but also all the rehab and seeing the specialists for a period of 2 years. So that really shows how broken this healthcare system is. And I would just conclude and say that if we're talking about the opioid crisis, single payer is the solution to addressing the opioid crisis. If you believe that abortion is a right, single payer healthcare is part of addressing the gaps in coverage for accessing reproductive rights. If you believe in mental health parity, single payer is the answer to mental health parity. If you believe that wherever you live, you should be able to access a doctor in your town, in the area, without paying any bills, getting quality health care, single payer is the only solution to that. This movement is growing across Massachusetts. Again, I want to thank the committee for having an early hearing, and really appreciate it for everyone who came in the auditorium. Thank you very much.
Good morning to the chair, people, and committee members. I'm Denise Garlick. I'm the representative from the 13th Norfolk District. I will be very brief out of the respect for the many residents of the Commonwealth who have traveled here to speak to this committee, but I pledge to you my assistance in any of the work that you are doing going forward. I want to wear, like many of you, I wear many hats. In this setting at this table today, the most important hat I wear is that of a direct care staff nurse for several decades. And I wanted to share with you my experience in witnessing the healthcare system. In the beginning of my experience, the healthcare pyramid to me had patients at the very top, and the foundation was the providers and the healthcare business, the way we did healthcare business. In that time, over the last several decades, I have witnessed a toppling of that pyramid, and now we see the healthcare business delivery system at the very top. It is pressuring the providers, regardless of their credentials or their titles, to be able to deliver the care that they know that individuals need, and it is crushing the needs of patients. This bill gives us a lens to address that healthcare business delivery system and ways that we could begin to address that. The second thing that I want to say is that any bill, just like any idea, can either be used as a tool or a weapon. It has been my hope in the years that I have spoken about a single-payer system, regardless of what we call the title, now we call it Medicare for All, that it is a lens that we can address that healthcare delivery system. But we must be cognizant of the immense power of the federal government in this kind of system and how we would change that, as well as the pressures of the many stakeholders that are involved with vast vast amounts of money. We must be very careful that we use this bill as a tool to bring together like-minded individuals and not allow us to divide us. And in the Healthcare Financing Committee, it is not only this bill, but the hundreds of bills that you are looking at that I am hoping that this bill is helpful to provide a lens to address those needs. Thank you.
Good morning. Thank you to the chairwoman, and I am delighted to see two chairwomen, so it's refreshing. I also want to thank the committee members who are co-sponsors of this bill, so Chairwoman Benson, Representative Cullinane, Representative Ash, Representative Barber, Representative Lutrino, Representative Higgins, and Representative Santiago. Thank you for being co-sponsors. When I was a child, my family spent a lot of time trying to impart sage financial advice. Put 10% of what you earn in savings, never buy something new when you can buy it used, and buy the best health insurance you can afford. I never questioned that last statement. It just made sense. Everybody knows that without the best health insurance possible, you end up with medical debt. And who wants to end up with medical debt? I started my own business, and I did just that. I bought the best health insurance I could afford. I was a sole proprietor, and no one in my family ever seemed to get sick. So I bought a mid-range plan and thought nothing of it, except every year when the plan renewed, and it was either stay with the same premium, but with a higher deductible and a higher copay, or pay more for a premium. We were okay, though, and I didn't spend a lot of time thinking about how really it's only in the United States where access to health care and health care coverage are directly tied to financial stability. Then, what happened to many families happened to ours. My partner got sick, very sick, with cancer. And right after the oncologist told us that he had probably about 27 small tumors in his lungs, she looked at me and said, "I'm really sorry, but we need to talk about health insurance." Because our health insurance wasn't going to cover continued treatment at that hospital. And so we left the emergency room that day knowing that it was probably cancer. We don't know what kind of cancer. We don't know where we're going from here, but please go home and find a hospital that will accept your health insurance. That day changed my life. I had been a proponent of single payer. I had been lucky enough to live in 4 different countries where there was single payer health care. And I hadn't put the pieces together. But I can tell you I put them together that day. The best health insurance that I've received has almost always been overseas, oddly. We talk about what a great health insurance system we have. But when I had near debilitating UTI, I was able to go to the urgent care center at Amsterdam Airport, get treatment, get diagnosed and treated so that I could get on a long-haul flight, and the doctor charged me 40 euros. Something here is broken. When I started to campaign single payer was one of the key issues I talked about. And I talked about it every day to everybody I met, on every single door, and I knocked on a lot of doors. Some of the stories that people said, please share, were the story of a man whose heart stopped while he was at work, a single father on Mass Health. And his story is, thank God I had Mass Health, but I promise you I will never take on more hours because that would mean I couldn't stay on it. A woman who had polio as a child, and because one of her legs was impacted, her health insurance currently only covers varicose veins in one leg, but not the other. A mother whose son had a stroke, her adult son had a stroke. She had to retire early because her health insurance company said they would only pay for half of the physical therapy sessions the doctor was requiring. Those are just some of the stories from my district, and despite the rain and the horrible traffic, a lot of people from my district are here today, and they're going to share a lot more of those stories, and I'm proud to be here to represent them. Massachusetts can and we must lead in the fight for truly accessible, affordable, quality health care. Medicare for All is about health equity. You should not receive better care because you have more money. You should not receive better care or better access to care because of your zip code. And you should not have to make important life decisions based on whether you can afford health care. That's why I'm here today to start this conversation about how we move Massachusetts towards a single-payer system. Let's take all of the testimony we hear today, report this bill favorably out of committee, and then begin the work of making it as strong as possible so that we can finally have a healthcare system that benefits every single resident of the Commonwealth. Healthcare is a right. Let's send that message today. Thank you for your consideration.
Thank you very much. Is there any questions? Rep?
Thank you, Madam Chair, and thank you to my colleagues who testified today. I have a quick question on Senator Eldridge. You mentioned tax for this or a tax for that. Are there any studies or comparisons to say to employers, okay, there's a tax for this. However, if you look at what you're paying, I don't know, say you're paying 60 or 75% of your employee's contribution, or to the employee saying you're paying 20 or 25%. These taxes that we're imposing to pay for it is actually less than what you're paying or more than what you're paying?
Yes, President, thank you very much for the question. So there was the national healthcare study that was actually done by Perry, the economics department at UMass Amherst. And the national study said that, first of all, that a universal Medicare for all system is less expensive than the current system, including all the contributions of employers, employees, co-pays, deductibles, premiums. So this state bill, which is very similar to the federal legislation, is that, yeah, employers would no longer have to pay premiums, and the payroll tax they would pay would be less than the premiums that they're paying. And so it would actually save money for employers, as well as the point that many employers say, I don't want to have my HR person be involved in choosing 5 often not very good health insurance plans for my employees. I want to focus on my business and making it successful. And that separates the employer-employee relationship as far as health insurance and allows the business to just focus on the business and not providing health insurance.
Okay, thank you. And the other thing is we've heard testimony on legislation about nursing homes and such, to saying that the reimbursements for, say, Mass Health or what have you, crippling some nursing homes, causing them to shut down because we're not paying this, the percentage that private industry may be paying. Would you see that a problem if we went to a Medicare for all, that our reimbursements down the road may cripple those places from staying open? Or would you see us having to increase what we're paying to keep these places open? I have a lot of seniors in my district, and they're nervous, as well as there are many facilities that have been closing down because of the reimbursement rate. Would that still be a problem, or would we have to change that?
First of all, I want to allow my colleagues to speak as well, but I would just say that it's important to understand that Medicare for all term, it's a term of art. It's a term that, the vast majority of Americans support of Medicare. The legislation itself would make sure there's direct reimbursement for all types of healthcare services, including, in my view, for nursing homes. And so, this isn't the Mass Health for All bill, right, where there's low reimbursement. This is the idea of reimbursement to make sure that hospitals are getting adequate reimbursement, nursing homes, doctors, medical professionals. And I do believe we can do that. And it's important to highlight that we did put in this bill, the taxes to pay for that.
Great. Thank you very much. Thank you, Madam Chair.
Chair Benson.
Thank you. Thank you. First, I want to formally apologize again for being late. A 2.5-hour drive is not typical if I leave after rush hour, but apparently there was no after rush hour today. But I wanted to state I am a co-sponsor. I am a big believer in single-payer health care. I have believed that my entire time in the legislature and before. And I had in the past also filed my own bill, but chose not to this session to support these bills in theory. So what I want to get into, though, is when we move out of sort of the theoretical support of single payer and actual implementation, it becomes dicey. And I think that I wanted to hear from each of you sort of your thought process around this. So understanding that we don't govern Medicare and we have no similar system in Massachusetts. Even Mass Health is run, the plans are private insurance plans. So we have no experience doing this. And upon passage and signing of this legislation, 90 days, we would be switching to a single-payer system. So my first question, and I'll kind of lay it all out there. So my first question is implementation. What is a realistic way of looking at implementation? Secondly, how long through this implementation would we need to have both systems running simultaneously? Because obviously we don't want anyone to go without coverage, and until we have this mechanism up and running, we can't force people off of their current insurance. So they would be paying both premiums and the new taxes to fund this system. So that's 2. 3, how would we address out-of-state employees, because they wouldn't be a Massachusetts resident and covered under this, but they would still be paying the payroll taxes if they're paying income taxes in Massachusetts. And so is there some sort of a waiver system that could potentially be included? I had one more question. I may come up with it, but let's start with that.
Well, I would just say one thing to reflect upon is that, in 1965, President Johnson signed Medicare legislation. So before that day, seniors had a variety of ways, often not very good ways, to get health care. Within a year, every single senior had Medicare. So, I do think that it's possible to expand health care access and make it a right in a similar way that happened with the federal Medicare legislation. In terms of how we would begin in Massachusetts, we would need to get a federal waiver from the federal government in order to implement single payer. The healthcare trust that would be created under the bill, federal monies would go to that trust, as well as the revenues that we're proposing here. And we do believe that that's sufficient to provide health care to every single resident. As far as the transition, I'd be the first to acknowledge that it's probably a number of years transition, and I have confidence that the legislature, state government would be able to come up with a plan to make that transition. But it's really critical to emphasize that, with the revenue we believe we could raise from that payroll tax and taxing those who are wealthy, we would raise the money to fund that direct reimbursement. And I personally think it would be a fairly smooth transition for people to go from the health insurance they have to direct reimbursement, because while they would be paying the tax, they would fairly quickly no longer be paying premiums, no longer be paying co-pays, no longer be paying deductibles, and they would see the value of that very quickly. I don't know if my colleagues want to add to that.
Go first, Lindsay. So Representative Sabadoza has chosen not to answer this. I would like to answer this in the way that I have seen Massachusetts move forward. We are not at the beginning of this conversation. We are in the middle of the conversation. I was a member of the Mass Nurses Association who supported single payer in 1990, and we have begun those discussions. The Healthcare Financing Committee has been integral to the work that we have done. In the early 1990s, we were heavily dependent on the Department of Public Health around healthcare quality and their department and how we were evaluating what healthcare was doing. The work that Massachusetts has done, we all know that the pillars of healthcare are quality, access, and cost containment. We certainly moved forward very rapidly with access and brought so many people into the healthcare system. We have been struggling since that time around cost containment, and we have not yet addressed, in my opinion, in its entirety, the issue of quality. What I will say to you, however, though, through the work of the Healthcare Financing Committee, we addressed in Chapter 224 ways to move forward. This committee had helped to develop the entire concept of ACOs in the Commonwealth, which is a way that we are beginning to streamline the care that we are giving. In addition to that, this committee set up the Health Policy Commission that is helping us to evaluate where our resources are. The conversation around single payer is particularly around the use of resources, and very bluntly, the waste of resources in redundancy, in procedures, in administrative personnel. The work of the Health Policy Commission is helping us to deal with that in a very concrete way. We've also seen a consolidation of the provider networks, and that was much more rapidly than I think any of us had envisioned. But even in that consolidation of the provider networks, we're beginning to see very thoughtful strategies around quality of care and around cost containment. I would make the case that this bill helps us, once again, to see that lens, but we are doing significant work in the Commonwealth of Massachusetts, and we are moving forward in a thoughtful manner. I want to respond to Rep. Altrino's question because I thought it was very thoughtful and very insightful. There are dangers if we do not do this thoughtfully and deliberately. It is going to take all of us working together to move forward. I believe that healthcare is a right. I am willing to work on that for the people of my district, the people of my Commonwealth, and the people of my country. And I do believe that we can accomplish this in a thoughtful, deliberate manner.
Thank you. Oh, I'm sorry.
I wanted to add quickly, because you had talked about the roadmap to implementation, that there are actually numerous studies that have been conducted for other states. So we've seen studies from California and New York, and quite frankly, in drafting this legislation, the federal study has been quite helpful and has highlighted things that I think Massachusetts is going to need to look at, particularly around how does this impact small businesses. So we do have guidelines, and I personally always look to the Canadian system when I think about how can we implement. Canada, as I'm sure you know, started with one province, and then it moved across. So we do have those ideas. Of course, our state is different, but we do have a GDP similar to that of Norway's, which manages to have single payer on its own. We have other challenges, but I think that the roadmaps are there if we, as Representative Garlick said, work together to look at them thoughtfully.
Great. Just to follow up, so my other question was about out-of-state residents who work in Massachusetts, but then also to follow up with the waiver. So our current waiver is good for another couple years, so we won't be applying for a new waiver for 2 years. And so moving forward with this now would be somewhat problematic because a big option or a big piece of what would need to happen is still 2 years away. There have been a tightening, not a loosening, of how those funds can be used under the current administration. So that would be also a real unknown out there. In fact, one of the conversations my staff and I have had is trying to think of a way of creating a public option as a way of transitioning. And the monies that come in for Mass Health, Medicaid dollars, really, we're not allowed to even be using them in that way. So there's a lot of federal restriction that we can advocate to change, but we can't change. So I'm curious about your thought process around the likelihood of a waiver, because that would obviously be a critical piece to this, but also how do we deal with out-of-state workers, which a federal Medicare for All system would automatically handle. So thank you.
Do you want to start?
Yeah, so as far as the waiver, I mean, we're certainly hoping the committee will report out favorably and act to establish Medicare for all and make progress this session. And with respect to the fact that the next waiver is not till 2 years, first of all, that's probably good news. I hope perhaps another person is in the White House in 2 years. And I think it's realistic to say that, you know, we would need a more robust waiver than we currently have. I think we recognize that this is a growing movement, and any advice that the committee has on how robust that waiver should be and what the specific details would certainly be helpful to, you know, the proponents of single payer. With respect to out-of-state employees, you know, certainly it could be an exemption for those that are earning are working here in Massachusetts but live somewhere else, because at the end of the day we're providing health care as a right for Massachusetts residents and not just for those, you know, not for people who are working here. So that could be an exemption where they're not paying a payroll tax and therefore they're not receiving health care as a right, and they will receive health care in whatever state that they live in. But I personally think those are things that could be worked out by state government and the legislature.
And I would like to add that we are submitting testimony from both of our senators and several of our congresspeople today. So we have a lot of support from our federal delegation. So in terms of making sure that we continue to get that waiver, it's heartening to know that they are behind us.
Sorry, not to harbor on this, but I grew up in New Hampshire and my family all worked in Massachusetts. So this is something that is clearly near and dear to me. But by not allowing people who are working in Massachusetts to get health care, they can't get it in their own home state because their employer would no longer be mandated to supply insurance coverage. So from a moral perspective, I think, we have to be very, very careful about not creating losers in sort of the whole region around us. So I'll just leave it at that.
No, absolutely. And some of the various roadmaps that have come out with different studies have talked about how to handle that, whether you have a provision where that health insurance is accepted out of state, obviously people travel with their health insurance, so if Massachusetts has a single-payer system, that could be an important thing that we need to cover as well. I mean, obviously, New Hampshire, in my area, a lot of people work in Connecticut, so we have that very same issue. But I do think that it requires all of us to really work together to figure out, like you said, that we're not going to have losers in the system, because really the goal is the absolute opposite.
Thank you so much. Thank you for your personal stories. Those are very helpful to share those. I'm curious, your interactions with 3 other countries, I think you said that you were?
I'm so sorry, I can't quite hear you.
You had indicated that you were in three different countries that have health? 4, okay. Can you talk a little bit more about those experiences, the pros and also the cons of those, of having that as well, if there are any?
I can certainly try. I was in different life experiences in different places. So I lived in China, the United Kingdom, France, and Italy. I received health insurance in China almost automatically. It was very easy, and I was actually there during the SARS epidemic, so it was kind of a fascinating moment to do that. And there weren't any real drawbacks, but I was much younger in life. I actually lived and worked in Italy for a much longer time, so I was paying into the system as well. I mean, of course, the drawback is that you are paying more, and especially in Italy, the taxes are much higher because they're covering health insurance as well as many, many other benefits that we aren't possibly addressing here today, things like childcare and free higher education. So that definitely felt like a drawback when it came to seeing my paycheck. However, I will tell you that when you can get a doctor to come to your house in the middle of the night when you have food poisoning, that doesn't feel like such a drawback. My partner, I mentioned his family is in Italy. He got sick here and ended up traveling back because we just had much better coverage to treat the cancer. I don't really know how else I can describe living in a system where when you need to access care, there are no referrals, right? You need to go to a chiropractor. You don't have to go to your general practitioner first. You can go into pharmacies and actually get the medication you need without going through multiple doctors to get various prescriptions. I mean, the drawback is the hospitals are not as fancy as here, for sure. They're not glittery and sparkly, and there aren't state-of-the-art services always. I misspoke. There aren't state-of-the-art luxuries almost, but the services are there. The basic services that you need are there, and I would honestly trade that for the system that we have here. Yes.
Thank you, Madam Chairman. How would this, how do you anticipate this would work if somebody, say, were in another state in California or some other state, pick it, had a critical car accident and was laid up and in a hospital in another state for an extended period of time, racking up literally hundreds of thousands of dollars worth of cost? How does this work to protect that Massachusetts resident?
I mean, I would assume the healthcare trust would just cover the health care for that person who's not from Massachusetts, similar to, people that travel to other countries and have a medical emergency or an accident. They go to the hospital and you're certainly not paying taxes to that country, but you get treatment. So I think it's just accepted as part of the system. And all things considered, I wouldn't think it would be a very significant cost, but it would be part of making sure that universal health care is there for, anyone who's in Massachusetts.
Right, so you would anticipate that the providers in another state that have a more traditional insurance setup would bill through their insurance to this trust and get paid from the trust. Is that how it would work?
Well, I honestly don't think there would be a bill. It would just, the person who goes to the hospital would have their health care taken care of. Who knows if they're paying a very small fee at the hospital, and then they go on their way, right? If it's a more serious incident, then the state pays the doctors who take care of that person who's injured. Again, it's a universal system where health insurance companies don't exist.
Well, they do exist in other states, and that's my question, is how do those insurance companies / providers and all of the stuff we know today that exists in another state interface with what this would propose as a single-payer system in Massachusetts?
Mm-hmm. It's certainly, Representative Garlick, yep.
Representative Hunt, if it's helpful to you, there is language in the bill that actually deals with emergency care and treatment of non-residents. The concern about that is that the language of the bill says that any non-resident will receive emergency care, and then the trust will try and recoup those expenses. There's also language in the bill that talks about non-residents and the care that they would receive, in which then they would be billed for services, but we're not clear about what that system would be and how we would bill non-residents for services.
Okay, my question is the opposite. I'm the person who's covered by this system here in Massachusetts, and I go somewhere else on vacation, get critically injured, and am laid up for 2 months in various hospitals and therapy, that type of thing, or at least to the point where I'm able to be transported one way or another back to Massachusetts. How do those other state systems bill for all of those services that are incurred by me in that other state? That's my question.
Yeah, I would suspect that if there's bills, say, out of California, you have an accident in California and there's bills, those bills are sent to the Massachusetts Healthcare Trust since the person is covered by the Massachusetts Healthcare Trust, and then the bills are paid to the provider in California. I mean, we're talking about fairly modest issues here. The real focus is on healthcare needs for Massachusetts residents in Massachusetts. I'm sure there will be some people out of state that have accidents, but I think we probably can acknowledge it's not significant.
One last thing, Madam Chairman, if I could. We do have a lot of people who are Massachusetts residents who are retired who spend nearly 6 months in other states, in the Sunshine States, who are elderly and require a lot of health care. So does this health care trust then just kick in and pay the gap that's created under Medicare federally for those people? How does that work?
I would imagine that's an accurate scenario, to make up the difference. Mm-hmm.
I just wanted to add that even under our current system, that is still a problem. If I go to California, that's actually what part of my story was. Not all health insurance is accepted at all hospitals. So if I go to California and they don't accept my health insurance, I'm also in a difficult position. This would allow the trust to pay, but that problem is a problem that until we take up healthcare federally, we're going to continue to see persist. And just in terms of traveling overseas, it really does depend on what your current insurance is. You don't know if you're going to be covered. I was lucky to be in countries where I was covered, but that is not true in the entire world.
I just want to ask all the legislators who are standing with us if they could introduce themselves.
Representative Mikhail Lugardo, 15 Suffolk.
Representative Mike Conley, Cambridge and Somerville.
Representative Hawkins, Attleboro.
Representative Michelle Socolo, 15th Middlesex, Lexington, and Woburn.
Representative Tommy Vitolo, Brookline, and to my left was Representative Jack Lewis, Framingham,
Yes.
and Senator Joe Comerford. She's a senator, so she probably has 25 different communities.
Franklin, Hampton, Worcester. And then there was also Representative Gouveia. Everybody's running today, so apologies. And Representative Wynn as well.
Great. So not to belabor this, but I think I just wanted to commend the members of the committee who are taking this very seriously. And these are a lot of the questions that we're internally talking about because it's not just about, as I said before, the ideal, which it would be absolutely ideal, but how do we actually get from where we are today to this? And there are so many questions and so much that we still don't really know. And I think that emergency scenario in California could easily be a very, very high cost and put a lot of wear on the trust fund because we wouldn't have negotiated rates. We would be paying list rates. We wouldn't be operating necessarily like a health insurance company that is, contracted. And I would also add that I think, as Representative Garlick mentioned, the success of the ACO model. The ACO model has been actually very successful in Mass Health, but that means referrals. That means, so we're in disagreement, or we don't know what the system would look like if you never need a referral and never need anything, and you can just go anywhere you want. Is that the best for patients, and is that the best for cost? So I think there's so many questions, and I will end with, we're working on legislation to address access and cost here in Massachusetts, and we're taking that very seriously. And a big piece of that is understanding adequacy. What is adequate for hospital payments? What is adequate for pharmaceutical payments? And these things are very, very hard to pin down, and there's a lot of variation. And so I think it's the complexity is not as simple as the tagline Medicare for all for us. Because if we could expand Medicare, the federal government needs to expand Medicare, period. That is the right solution that could be done easily, so to speak. But we have to create an entirely new system and answer all of those questions on our own. And so I think I just want the public to understand that we take this very seriously. I think we all agree on some level that this is the right way we should be going, but it's getting from here to there is the question. So thank you. Thank you all for coming forward.
And Madam Chair, if I could just offer two final comments, is that, I think the issues you raise about the complexities is because of the healthcare system we have, and so the problem is just playing around the edges is not going to address costs, it's not going to address universal coverage, it's not going to address the deep inequities in the system, and that's why, we're all here to argue for a totally revolutionary system that changes the current system. And if you're just working around the edges, you're not going to address prescription drug costs, you're not going to address rising deductibles, you're not going to address rising costs for employers. My second point is that, sort of related to the emergency, is recognize there are Massachusetts residents here who have healthcare emergencies and have to file for bankruptcy, okay? So put aside the California example. There are Massachusetts residents here that are having healthcare accidents, tragedies, and are paying hundreds of thousands of dollars out of pocket or filing bankruptcy. That is outrageous, and we need to fix it. Thank you again for hearing us out of turn. Appreciate it.
Yeah, thank you. Thank you for your testimony, and I understand. And I just want to echo what my chair said, that co-chair said, is that we are taking this very seriously. I think one thing I would like to see, and I think it's to, I can't remember whose question it was, but there are going to be changes if we do this, big changes for people. I would maintain that today we absolutely ration health care because and we ration it based on whether you can pay or not. But Medicare, very transparently, is very clear about what they will cover and what they will not cover. And people need to understand that when we go to a system like Medicare, we're making those decisions. They may be great decisions, they may be the right decisions, but they are decisions that people are going to make. As somebody on Medicare, again, I have access to great health care, and there are things that Medicare says, no, we won't cover that. So I just don't want to set up this ideal that if we go to a Medicare for all, we go to single payer, that all of a sudden everybody is going to have access to every single thing they need when they want it, if they want it. And I think part of what we have to do in order to get to this, to a single payer system, is to bring the public along with us. And the only way we could do that is to be really transparent, be really clear about what this is going to mean, what it's going to look like to them, what it's going to cost, and what the trade-offs are. And I absolutely agree, this is a broken system. I can't defend any of this. But we are, when we make those changes, we will be unsuccessful if we can't bring the public along with us. And in order to do that, we have to have the answers to all of these questions so that we can be honest and there's a trust there. So I just thank you for all of your comments and your questions. I really appreciate it, and thank you for coming.
Great. Thank you very much.
Rep. Hawkins, did you want to testify on something? Okay, why don't you stay and you can.
Thank you.
Thank you very much for your hard work on this very important issue, and we recognize it through all of your questions and through the testimony of my colleagues how complex this is. It's probably the biggest issue that we're going to challenge in the State House, and thank you for all of your work. I just have a quick personal story to share from my view on this. Other reps have already shared their personal stories, so I can as well. I will be turning 70 later this year. I had Clark's type 4 melanoma cancer when I was in 95, and I'm currently diagnosed with Waldenstrom's, which is an incurable blood cancer. And I don't say that for sympathy. Obviously, I'm fine right now. It's coming. But I could not be higher maintenance right now, either because of my age or my medical history. And insurance right now, I don't have state house insurance. I have my own that I brought with me. Is the cheapest it's ever been on Medicare. So my thought is it's worth all of your work. This is a system. There's possibility in this. This can work. And I get it with the complexities. I don't mean to ignore that. But thank you very much for all of your work.
Thank you. Thank you for sharing the story. Any questions? Okay. Rep. Hogan, I think, came in.
Thank you, Chairs Friedman and Benson, and honorable members of the committee. I am here today in support of House 1163, an act establishing a special commission to study the implementation of single-payer health care for the Commonwealth. I want to emphasize the critical importance of our shared goals of affordable, transparent, and accessible health care for all of our residents. Our state is the leader in healthcare equity, and still we are failing too many of our constituents who are falling through the gaps of proper care. The single-payer healthcare system is increasingly proposed as a transformative solution, helping to get more people to the doctor's office while reducing costs. However, there has never been a study here in Massachusetts on the cost and feasibility of implementing it at the state level. That is the mission of this information, and really it is about information, and that is the mission. The fact is that the move to single payer is a big change with a big price tag. We must be able to communicate to constituents what it will cost them and how it will affect their bottom line, which means we need to be able to effectively communicate what it is worth. This bill establishes a cross-sector commission responsible for investigating the questions we know we will face at every turn. How will it affect the bottom line of individuals and small businesses? How will it impact quality of care and our state's leadership in medical innovation? How will it work for providers? What model of single payer would work best for the Commonwealth? I need to be able to tell my constituents that I know the single-payer system we adopt will cut cost, be more affordable and accessible, all the while sustaining the Commonwealth's high standard of care. I need to be able to say that our health care policy was shaped by a wide group of stakeholders with diverse backgrounds and points of view, and that it was written based on research consensus and the experience of those who do this work firsthand. Steps matter. Look at how far we have come since the implementation of Chapter 224 in 2012, the nearly universal rate of coverage, though it is not universal, and that is really important for us to understand. The significant culture of support we have today for affordable health care. These steps are what makes the conversation possible. And bills are living, and I look forward to working with the chairs of the committee and stakeholders to establish the best single-payer commission possible. We want the same thing. I think all of us that sit here talking about a possibility of working towards a single-payer system. H. 1163 commits to building on this collaborative and rigorous approach to health care that got us where we are today, ready to take the next step with a shared purpose and a profound sense of what is at stake. I would like to thank the chairs and the members of the committee for your leadership, and I respectfully request a favorable report. Thank you.
Thank you. Are there any questions?
Good.
Thank you very much.
All right. Thank you all.
John Robinson.
First, I'd like to say good morning to the chairwomen and all the rest of the members of the committee. Thank you. My name is John Robinson. I'm 70 years of age. I live in Somerville, Massachusetts. Can you hear me? And I'm a member of, supporter of MassCare, member of the Boston Center for Independent Living, the Massachusetts Senior Action Council, and because of my disability, I was not drafted for Vietnam, but I am an associate member of Veterans for Peace. I come here today to support single-payer health care. That's H1194 and S683. I was born physically disabled because of a premature birth. I have retinopathy of prematurity, and it's called retrolental fibroplasia. I'm legally blind in one eye and visually impaired in the other, so I ask for your patience with my visual problem. I'm going to be very brief. The main thing I want to stress is that Massachusetts, as you all well know, is one of the most unequal states in the country. And many people can't afford health care, even if they are insured, due to high out-of-pocket costs. Now, that happened to me. I happen to be in the classification where a lot of people would call me working poor. I was lucky to finally land a job with the railroad, and ended up as a coach cleaner before I retired when I was 62 years old in 2011. I fell off the health care cliff, consequently, and I had to get health insurance when I was 65, and I found out this is not something that I can afford. Consequently, I pay a lot of money for health care insurance to have access to health care. I won't tell you all the costs. I'll just give you the totals. $430.09 a month that I have to pay out of pocket, as well as for out-of-pocket expenses that Blue Cross Blue Shield or Delta Dental or WellCare Health Plan don't cover for prescription drug costs. So in addition to that number that I gave you, I'm living on $1,449.74 a month. They take out $135.50 for Medicare, and on it goes. So with that in mind, I just want to stress that we waste more than 30% of health care dollars on an expensive insurance system that only rations health care. And I would ask you to please take that into consideration. I know you know the facts. And the last thing I'll say is, does the Massachusetts legislature have a plan on how to manage this growing crisis that threatens our economy and our health? And in closing, if you're familiar with the Veterans Administration, today there are 49,000 vacant positions at VA hospitals across America. Most are vacant doctor, nurse, and mental health positions. This is going to affect us in Massachusetts. It's already started. So on top of that, I'll close with this, I'm sorry. According to Public Citizen, more than 30,000 Americans are dying every year because they are locked out of the profit-driven healthcare system. And that means roughly 100 Americans die from lack of health coverage every day. And I think it's a moral outrage and an atrocity that this is happening in the richest country in the world. So I thank you very much for your time.
Thank you. Are there any questions or comments? Thank you very much. Thank you for coming.
Thank you.
Maria Termini?
Good morning. My name is Maria Termini. I live in Roslindale. I'm an artist and an activist, and I am compelled to advocate for what I believe is justice in healthcare, which would be Medicare for all. I'm speaking in support of Senate 683 and House 1194. Many people continue to suffer and die because of our extremely expensive, horrendously complicated, broken, fragmented healthcare system. Many people are denied care. In my own case, I've had 2 very, very serious knee surgeries in 2 years. The only way I could afford them was to live in poverty and qualify for Mass Health. So I got the surgeries, but I had the challenge of living on $739 a month. Not easy. I am surrounded by stories of people who don't get the health care they need. I have a friend, Melinda, who's a single mother. She takes her daughter to see a doctor. Every time she visits the doctor with her daughter, it costs her a $70 co-payment. My friend Melinda makes barely above the minimum wage. So she does take her daughter to see a doctor, but she can't afford health care for herself because the co-payment is too high. Our system does not cover comprehensive health care. The last time I looked in the mirror, my teeth were part of my body. I heard a horrible story about a little boy in the Midwest. He had a toothache. His mother had health insurance, but it didn't cover dental care. The little boy went without attention to his toothache. It developed into a brain abscess, and it killed him. I was very, very saddened by that story. The high cost of prescription drugs is increasing the suffering. Many diabetics cannot afford insulin and have died, and this angers and saddens me. Medicare for All would provide us all with affordable prescription medication. A couple years ago, I was in Bolivia. I got bit by a dog. The rabies shots in Bolivia were $35 each. So I got 4 of the shots in Bolivia. I had to get the 5th shot. I was back in the States. When I got the 5th shot, it was $1,200 for the exact same medication. We need to understand that exploiting sick and suffering people to make a profit is wrong. That's why we need a nonprofit, simple, single-payer system, improved Medicare for all. Thank you very much.
Thank you very much. Are there any questions or comments? Thank you for your testimony.
Thanks.
Kaylin Abazed.
Thank you, Madam Chair. My name is Kaylin Abuzaid. I'm a 21-year-old college student from the Boston area, and I go to college at Bates College in Maine. I'm giving my testimony in favor of H1194 S683. During my freshman year of college, I worked as an administrative assistant at the Renfrew Center of Boston, an eating disorder clinic. While I was there, we had a 16-year-old girl who had finally come in for treatment after battling with her family for months. She walked into the clinic on her first day looking close to death. I could have easily fit my hands around her arms and legs. Her skin looked paper thin, stretched over her tiny body. She was extremely quiet, raising her voice to a soft whisper when I asked her questions. After her intake appointment, it was clear that she needed to be sent to our residential program in Philadelphia. Her insurance wouldn't cover it. The next highest level of care was our day treatment program that ran 5 days a week, 8:30 to 3:30. Her insurance wouldn't cover that either. We had to settle with her enrollment into our day intensive outpatient program that ran from 10:30 to 3:30, 3 days a week. Her insurance gave us 3 days before her case had to be reviewed again. For 3 weeks, the staff battled with her insurance company, trying to buy her more time and the higher level of care she clearly needed. As someone without a medical degree, I could not directly fight the insurance company myself, but I did my small part to help. I did my part by being meticulous about the insurance aspect of my job. I triple-checked the patient's daily status before sending it off. I made sure I filed her treatment information correctly, and I accurately documented her granted coverage. At the end of her first month in treatment, her insurance company decided that she'd had enough time in program and no longer needed coverage. Our psychiatrist petitioned this denial and lost. With no other way to pay for treatment, we were forced to discharge her from the program. We never heard from her again. This incident was one of many I saw during my time at Renfrew. It brought my attention to the barrier insurance poses to getting access to mental health care. It made me much more aware of how uninformed insurance companies are and how their system is not designed to benefit the patient. 2 years later, when I joined this movement for single-payer health care, I was immediately brought back to my experiences working at the Renfrew Center. Fighting for a single-payer system is a fight for all the women and girls I saw who were never allowed to access the help they desperately needed. Thank you.
Thank you very much. So powerful testimony. Any questions or comments? It's a broken system.
Yes, thank you.
Donald Green?
I have a very soft voice, so I want to make sure people can hear me. Good morning. Was it morning yet? Still, we've got a couple of 30 seconds, I guess. Good morning, legislators and Commonwealth residents. My name is Dr. Donald Green. I'm a retired Reading family physician practicing over 30 years in this state. And I did it in every area of medical practice. That means in the hospital, in the office, the nursing home, and in people's own homes. The present system is too expensive. It has barriers to proper care and uses solutions that interfere with healthy doctor-patient relationship. An expanded Medicare for All law will bring more comprehensive, affordable care to all in this Commonwealth. And I'm talking about the bills S683 and 1194. Winston Churchill once said, "You can count on Americans to do the right thing, but only after they've tried everything else." Well, we have come to the right thing, and it's time to make that change. All the complications and nuances I hear are because of the complications of the system, and it needs to be simplified. We spend 18% of our GNP on healthcare in this country. Canada spends 10%. So if you want to spend more on a system, you have some leverage between 10% and 18%. Every country gets to decide how much they want to spend on healthcare. In fact, it is no matter whether there's single payer or there's not single payer in countries or in entities, financing healthcare is always a problem because the growth of expenses is always going up. So it will be a battle every year. In fact, you see it in the premiums as they rise every year. So what saddened me when I was in practice, patients would arrive who had to end a 15 to 20-year relationship with their doctor because their insurance changed. And employers change their insurance about 25% of the time. So about this thing about choosing your health care, this is a myth. Payments for care were not based on service rendered, but on what card a patient had. Besides the billing nightmare it causes, it added unnecessary expense. You look in the billing departments of hospitals or doctors, if those could be reduced down to a number, this is extra income to finance health care. In fact, this is where the biggest savings is in Medicare for All. It is in the overhead costs. Medicare works on a overhead of 3%. Private health insurers and nonprofit insurers work anywhere from 10 to 30%. It was disturbing to see my fellow physicians refuse to see Medicaid patients. In my community, our practice was the only one at that time to see these patients. Contrary to popular sentiment, it only enhanced my professional and economic life. The kind of economics that doctors don't realize sometimes because they're not always the greatest business people, but how much you earn from a patient is what the charge is for the visit times how many visits they have a year. Well, people who are on Medicaid or on Medicare have about 2 to 3 times the visits that the regular population has. So they are not, they actually enhanced my bottom line. They didn't detract from it.
May I ask you to wrap it up a little bit?
Excuse me?
Can I ask you to?
Oh, sure.
Thank you.
So in conclusion, affordable personal care, I don't exactly look at it as a right or an economic choice or an entitlement. In this day and age, when a person's proper survival depends on the ability to see a doctor, that makes it a necessity.
Thank you. Thanks for coming in to testify. Any questions? Nope, looks like we're all set. Thank you, Doctor. Stephanie Nagayima.
A couple couple of years ago, I was diagnosed with high-risk HPV, which is an STD that causes cervical cancer, an extremely common form of cancer. HPV itself is also extremely common, affecting 80% of women at some point in their life. I hope I have all y'all's attention. The vast majority of people will kick it within a year. The body has to fight it. There's no treatment or cure. In a small number of cases, the virus will linger for years, and that's when it can be a problem. So my doctor said, let's wait 1 year. This was the first year that I'd ever been tested for it. We had no idea how long I'd had it either. But let's wait a year and see if it clears up. Next year, I still had it, so I went in for what they call a colposcopy, which is when they just look and see if there's any cell changes. The good news is that I didn't have any cell changes yet, but the copay was $540. $540 is over half of my rent, and my rent and utilities together is over half of my take-home pay every month. This was something I was supposed to do every 6 months. And you may think, maybe you just had really bad insurance. Actually, I do and still have the same plan as a platinum plan. It's the best you can buy on the individual small business market. I get it through my employer, which is a small nonprofit organization. So next year at my annual physical, I still have the virus. Like the year before, I had no idea how much it was going to cost beforehand. It can only be more, really. So my doctor says, well, let me just look more closely at the virus. I'll see if, it's one of the strands that are much more likely to cause cancer, one that's less likely to cause cancer. And they look at it and they decide, well, this one is, obviously they all cause cancer, but this one is less likely to cause cancer quickly. So we can just wait another year if you think, you're going to be okay with that. And she said, if you still have it next year, I'm going to insist that you just go ahead and do it. And so I did wait another year. And the next year, I was fortunately free of the virus. But for many years, I wasn't really sure what I was going to do if just the diagnosis was going to be $540, and that was something I'd have to pay every single time. Women make less money than men, both for the same work and more dramatically overall. This is sexist, and so is our healthcare system. Yes, gender rating was made illegal by the ACA, so women can't be charged higher premiums than men, but women will always need more healthcare than men. And as long as we have a system that allows co-pays and co-insurance, deductibles, any kind of cost sharing, insurers will find ways to shift more costs onto the patients. This, of course, disproportionately affects women, low-income people, and sick people. Massachusetts is proud to be one of the states that have dropped the tampon tax. I hope I've shown you today that women's barriers to potentially life-saving healthcare in the state of Massachusetts is real and cannot be fixed by measures such as repealing the sales tax on menstruation products. The only healthcare system that can actually respect the rights of women and their right to healthcare is a single-payer healthcare system. And just to say one last thing before I finish, I've lived in Denmark and I've lived in Japan, and feel free to ask me any questions about those systems. I've seen the pros and the cons, and to tell you the truth, I'm still terrified of getting sick here. Thank you.
Thank you very much. Are there any questions? Thank you. Kimberly Connors, Calvin Tompkins, Dr. Bill Taylor, and Jane Cherloff.
Good morning, Madam Chairwoman. Thank you very much for having us today. My name is Kimberly Connors. I'm part of Progressive Mass. I live in Maynard, Massachusetts. 3 years ago, I was in cancer treatment. And when I got my diagnosis of stage 2 breast cancer Before I even had a treatment plan, I was advised to go to the financial office. It is what they do when you get a cancer diagnosis. We were to figure out what my co-insurance was and how much I would have to pay for out of pocket. That amount right now in 2019 is $7,900 for an individual, or $15,800. That's the cap. I had the wicked good plan, so that meant I would have to pay 10% of my total treatment. During my treatment, I was fortunate enough that I could go to Mass General. I could go to Emerson Hospital, Acton Medical Associates, my local pharmacist, and every one of those had to check every time I had a new procedure, every time I had a new medication, every time I had a test ordered. They all, the extreme redundancy will drive you crazy when you're in the system and it's your life or your death. One of the first things I learned is that people go bankrupt. They lose their homes, usually 4 to 5 years after the treatment. Because they use their life savings to do the co-payment, they take out second mortgages on their home, and they can never make up the income that's lost or what they paid into the system, so they end up going bankrupt. The other craziness was that I worked during my treatment. I had no choice. I'm a self-employed archaeologist. Even people that have employee-based insurance are afraid to leave work. They want to guarantee that their insurance will be there when they need it, so they work during treatment. I was denied treatment by insurance companies. I was denied medication. I was denied tests. We constantly had to appeal these denials. Here I am, I could barely get out of bed. And all I'm worrying about is whether or not my next treatment had been approved. I've often thought they were just waiting for me to die. But here I am, and I know that there are people in the system right now with catastrophic illnesses that feel lost and alone. I'm here fighting for them, and I hope that you report favorably on the Medicare for All bills before us. Thank you very much.
Thank you. I just want to remind you that we're trying to keep the panel to 9 minutes.
Okay. Hi, my name is Jane Chertoff. I am a retired teacher from the Arlington Public Schools. I live in Hudson. And I just want to make a brief statement contrasting sort of the inequality of health care. As a teacher, I had health care. I started off not even having to pay into health care. Then I paid in, but there were no deductibles. Then GIC took over, and we did have deductibles, but Arlington had a special fund from getting into the GIC that paid that. So basically, I never paid for my health care the whole time, and now the only perk of being 65, I'm on Medicare. I just want to contrast that with friends I have who aren't part of any companies that will sort of subsidize their insurance. They've had to, my friend is a cancer survivor, and they've had to buy off of the health connector, and they have to pay $2,700 a month just for the insurance. They have $6,000 they have to pay before it kicks in. And they're lucky enough to have that money. But I know many people who won't go to a doctor because of the deductible. So it just shouldn't be like that. My brief statement. Thanks.
Hi.
My name is Calvin Tompkins. I'm a 17-year-old from the Merrimack Valley, and I rise today to speak in favor of this proposal for one simple reason. I want to live. I'll keep it very clear. In America today, Americans like me are living in fear. Fear from the fear of the federal government rescinding healthcare options and funding for Americans with pre-existing conditions like me, and insurance companies that are actively trying to remove us from their claims. Though I only have 3 minutes, I can only begin to describe the attacks on diabetics from those who wish to profit off of our conditions. Today, thousands of people face possible death due to dangerous and outrageous decisions from health insurance companies, due to the constant siege by them upon us. Often, we are struggling for basic coverage, resulting in worsening health conditions, and in the most horrific scenarios, insulin rationing. I myself did it last year, and as a result, I almost died. Like, that, I want to stress that. I almost died because I wasn't covered by my insurance company. They denied my claim. This is beyond insane. While a vial of insulin, something as small as this, I want you all to look at this, as small as this, can cost $300 a month, per vial. It can cost over thousands of dollars just a month to pay for something as small as this. In Canada, 200 miles north, this is $38. $38 for a month's supply. So kids like me, the second we graduate, once I'm 18, which is like in a year or so, I am going to have $25,000 a year just to pay for basic insulin. And that's not even including my regular medical expenses. Sadly, thousands of people like me are going into debt because of this. Look, I rise today not only for myself, but for those that have died because of this before me. I shouldn't have to decide between going to college and paying for my medical bills. Right now, me and my mom and dad, we're having a discussion whether or not I can even afford to go to college because of my meds. So I want to be a productive member of society. I really do. But this isn't fair. And I simply cannot afford to live because of my diabetes. And I rise in favor of this. So, look, I was born with this disease, but I'll be damned if I let it kill me. It is only you, the members of this legislative committee, that can actually help people like me. I beg of you, don't let another one of us suffer the same plight. Please pass this bill.
Thank you very much. I do say that I've enjoyed the committee's discussion and questions. My name is Dr. Taylor. I was earlier on a panel with Kimberly and also Jamie Aldridge and Maynard on Medicare for All. And I have a few points I would like to make. First of all, I'm an expert, no one's an expert, but I have worked in Medicaid and Medicare as a physician. I also volunteer with the Minuteman Senior Services, an agency that receives federal funds to support the elderly at home. The first thing I wanted to say is there have been wonderful economic studies on how much countries spend. And a publication recently, 11 high-income countries in the world, the U.S. spends number one and has for years. If you look at the other 10, they spend half of what we do. And those countries are Europe, we're talking about Scandinavia, we're talking about Canada, Australia. Now, why is there a difference? Well, the big difference is all 10 of these are single-payer healthcare systems. And I want to emphasize that single-payer is not experimental. These systems have been studied. They're all a bit different according to their cultures, but they're viable and they're spending wiser than we are. The second point is the healthcare budget, of course it's been going up for decades, is $3.5 trillion. So every one of us should be consuming $10,000 a year, right? The problem with this is the distribution of services I don't think meets population needs. I look at that $3.5 trillion, 53% go to hospitals and physicians. If I look at long-term care supports, only 10%. If I look at public health, 1%. Government-sponsored research, 2%. So I don't think this mixture is ideal going forward. The government's Council to Address Aging in Massachusetts describes the financial burdens of the middle class living at home. 42% of single older seniors cannot pay their medical and their housing expenses and make ends meet at the end of the month. 25% of couples are in the same situation. These are people that are going to have to leave Massachusetts to survive. I support this act establishing Medicare for All. I think it's moving in the right direction. I think we can get the answers to operational questions from many of the other countries. We'll need to fine-tune it based on our values. But I support moving forward with the Senate Bill 683 and also the House Bill 1194.
Thank you very much.
Thank you.
Are there any questions? No, thank you for coming. Thank you for your testimony. And if you have written testimony, could you be sure we get it? If you have written testimony, can you be sure we get it?
I've submitted that to both
Great.
of the
Perfect.
chairs.
Thank you. Nathan Cohn?
Thank you, Chairwoman Friedman, Chairwoman Benson, and the rest of the committee who's here today. I'm here representing Progressive Massachusetts. I serve as the chairman of the Issues Committee. Progressive Massachusetts is a statewide grassroots advocacy organization devoted to shared prosperity, racial and social justice, good government and strong democracy, and environmental protection. Medicare for All is a quintessential part of shared prosperity, and we are proud to support S683 and H1194, an act establishing Medicare for All in Massachusetts. Massachusetts has a storied role in the history of the fight for universal health care in the U.S. Our former Senator Ted Kennedy was a longtime champion of single payer, and our 2006 health care reform law was a model for the Affordable Care Act nationally. Although our health care reform law, boosted by the Affordable Care Act, has helped Massachusetts achieve near full universality in health insurance coverage, we still see underinsurance, high premiums, some of the highest in the country, high rates of medical debt, and significant disparities, all inevitable outcomes of a reliance on private sector provision. Universal coverage alone doesn't guarantee affordability, quality, or equity without additional steps. These problems will continue to exist as long as we treat healthcare as a commodity instead of a right. The U.S. remains the only advanced industrial country that does not recognize this as a fundamental right, but Massachusetts can lead the way. A single-payer system would save the Commonwealth money through increased efficiency, take the burden of rising healthcare costs off small businesses, municipalities, and families, eliminate medical debt and medical bankruptcy, and finally guarantee access to quality, affordable healthcare as a right. I would also speaking, I'll be brief here. We also oppose H1163, an act establishing a special commission to study the implementation of single payer. Commissions can be valuable tools, and I know the Senate bill S674 is perfectly fine and models bills that have been filed in the past. However, with H1163, although like the Senate bill, it would give space to CHIA and the HBC in the commission. It would also include spots for the insurance lobby with Blue Cross Blue Shield and the Massachusetts Association of Health Plans, as well as the Health and Hospital Association. The hospital and insurance industries have spent large sums against Medicare for All and are often large opponents here at home. And we don't need to fund a commission to know what the insurance industry, where they stand on Medicare for All. we can Google that. And similarly concerning the commission as designed in H1163 designates a spot for a representative of employers, but no representative of workers, and includes no space for patients' rights. Finally, the way we design our healthcare system has a significant impact on the lives of all of the residents of the Commonwealth, and putting equity and justice at the center of such a design is vital to ensuring that every person is able to live up to their full potential. Thank you so much.
Thank you. I think we have a question.
Yeah.
Yes, thank you.
Yeah.
So I just have I agree with everything you said.
Yeah.
I have a quick question, though, with the commission. Do you
Yeah.
think there is room to have providers as part of the commission? Because I think the idea was with the
Yeah.
Health and Hospital Association that would be
Yeah.
a provider voice. But do you see Mass Medical Society or any of these organizations that are provider organizations?
I feel like a representative of doctors kind of makes more sense than like a representative of hospitals, as well as just balancing it out, at least in the sense of like making sure that you have patients' rights advocates also represented, so that you are actually having the full spectrum of people who are affected by it.
Thank you.
No, thank you.
Thank you. Any other
Can I have written
questions?
whom should I
Great,
pass
just
this on
right
to?
at the end there.
Okay. Thank you.
Thank you. Rep. Gouvet, are you here to testify?
Madam Chairwoman, members of the committee, thank you for this opportunity to speak in support of House 1194 and Senate 683. I know you've been hearing lots of stories from folks who have been testifying. I just want to give voice to a couple stories that I heard from constituents of mine, one of whom is a father who watched his 10-year-old daughter survive from leukemia, but now he's forever concerned that she will be able to access health care and have this sort of stigma of a pre-existing condition. I've also heard stories of people really struggling to get care for their aging parents, get access to specialists because they weren't in the right network. And I know that's not exactly what we're talking about here in terms of pre-existing conditions, but I am very worried about what's happening at the national level, the ongoing conversation around the ACA, and how that could impact residents here very real ways in Massachusetts. I also want to talk about two other things. One, I have worked in the field of opioid prevention for about 15 years. I just got back from a trip from Portugal and had the opportunity to do multiple interviews and observations of their system and how they have approached the issue of opioid addiction and other addictions to substances really with a public health and medical focus. And one of the things that they said to me over and over and over again is, but in the Massachusetts and in the United States, you do not have single-payer health care. And because we have single-payer health care here in Portugal, we have a much easier time making sure that people get access to the services and to the treatment that they need and deserve, because there aren't silos between the systems. It's a very seamless situation where a medical health care provider can make a referral to a behavioral health specialist or to an addiction treatment specialist. And our system continues to be very siloed here that leaves people falling through the cracks every single day, which is causing people to not get the treatment that they need and contributing to our overdoses. Portugal has seen a huge decline since the late 90s and early 2000s in opioid overdose deaths, and part of it is because they were able to address it with a much more comprehensive approach to health care, because they have a single-payer health care system that they were able to leverage. The other thing I just want to mention is job lock. I don't know if anybody has already given voice to this or not. I had to step out of the room for a few minutes. But I hear from friends of mine, from colleagues, from constituents that they are forced oftentimes to take a job that they don't necessarily have the passion for, that is underwhelming to them, and that is not in line with the skills that they can offer to an organization, because they have to choose a larger corporation to work for so that they can get access to a better health insurance plan, perhaps because they have diabetes and they're concerned that soon they won't be able to afford, that their share of coverage will be so high that they won't be able to afford the care that they need. With chronic conditions, this is a real big problem. We know we have a rise in diabetes over the last 2 decades. So this is a real concern with job lock, people not moving into positions that they could otherwise be better contributing to. And this has a huge impact on our small businesses and our local economy. So for those two reasons, I support Medicare for All, in addition to all the other reasons that people have already said before me. Healthcare is a human right. Our system, we've made tremendous strides, and I appreciate all the work of the committee and committees before us and the legislature before us that have made Massachusetts really put us on the map and be a leader in healthcare and the way that we approach health insurance. But I think there's much more that we can do. So I thank you for your time and willing to answer any questions that you have.
Thank you so much, and thanks for coming back.
Oh, you're welcome.
Do we have any questions from members of the committee? No? Thank
Great.
you.
Thank you.
Rep. Sabadosa, are you testifying again? Okay, I just wanted to make sure. Okay. Do you want to go?
Sorry, but William Taylor. Is William in the room? Mark Marasco.
I want to thank Chair Friedman, Chair Benson, and the rest of this joint committee for listening to my testimony today. I am speaking in support of Medicare for All, House Bill 1194 and Senate Bill 683. My name is Mark Marasco. I'm a 16-year resident of Amherst and a former small business owner. My team of 23 employees has provided warehousing and trucking services throughout the Northeast region for over 30 years. During that time, I found that the growing complexity of providing health care is unfair to my employees and a significant burden on my business. Employer health insurance plans change every year. Each year, the cost and complexity of insurance options increases significantly and unpredictably. Each year, the choice of deductibles, copays, coinsurance, provider networks, and prescription drug tiers affects each of my employees differently. It is an unfair system because the employer chooses the product, but the employee is the actual consumer. My expertise is moving freight. I am not a healthcare expert. The time and resources I spend on reviewing plan options, re-enrolling if we change providers, educating employees on changes, and keeping current on regulations are resources not spent on my core business. We get bogged down with managing HREs, HSAs, EMAC contributions, and PCORI fees. Our premium costs are based on our pool of employees, which is not a level playing field for competition. Each employer provides insurance plans differently, which is not fair to employees. The current system is very inefficient for employers, for individuals, and for care providers. Under a single payer system, the complexity of insurance options goes away. Payment streams are simplified with no premiums, no deductibles, no copays, no coinsurance, and no prescription drug tiers. There is no need to educate employees each year on how to pay for health care. There is no need for re-enrollment and all the associated costs of changing to a new insurance provider. A single payer is staffed by healthcare experts who are driven by controlling costs and the public good, not profits. Business owners can focus their resources on their core business, which is the most productive use of those resources. Unpredictable insurance premiums are replaced with a simple payroll tax that applies to all employers equally. Everybody has the same coverage, not various plans based on their current employer. It's much more efficient for employers, individuals, and for care providers. Massachusetts has been a leader in healthcare reform in the past, and I urge you to pass this act for Medicare for All without further delay so that we can be leaders again.
Thank you very much.
Are there any questions?
Are there any questions? Thank you.
No.
Oh, is William Taylor? Donna Kelly Williams, Katie Murphy, and Patricia Healy. Hello, nurses.
Hi, everyone. My name is Donna Kelly Williams. I am a registered nurse and have been at the bedside of patients for almost 45 years. I am also the president of the Massachusetts Nurses Association, and we represent approximately 23,000 registered nurses and healthcare professionals across the Commonwealth. I am here today because the Massachusetts Nurses Association has endorsed Senate Bill 683 and House Bill 1194. Both would establish a Medicare for All system in Massachusetts. I ask that the Committee on Healthcare Financing report this legislation out favorably from your committee. You will hear from many people today about the many benefits to implementing a Medicare for All system in Massachusetts, including the health benefits, which my colleagues Katie Murphy and Patty Haley will speak to. But I would like to focus my remarks on the impact on the current health insurance system on union workers and how the existing system is harmful to them. Why the current system is problematic? Employee health care costs often dominate labor negotiations. Take, for example, this is an all too typical scenario. As the cost of providing private health insurance increases, employers look to shift the cost burden onto employees. Workers are then confronted with a base increase in the cost of the insurance product and proposals to pay a higher percentage of the premium, higher deductibles, higher copays, and/or increases to coinsurance. Now workers have to focus collective bargaining on health care costs rather than on patient safety, working conditions, and wage increases. The long-term effects are the increases in private health insurance costs have created downward pressure on wages for union and non-union employees. According to a report by the Social Security Administration, as real wages have stagnated, contributions for health insurance have continued to rise, climbing from 3.7% in compensation in 1980 to more than 7% of compensation in 2010. That is a significant loss for the American worker. Families are paying more in premiums, deductibles as a share of their income more than ever before, and this is true for both union and non-union workers. Unions like the Massachusetts Nurses Association support single payer because it will save money, increase real wages, expand access, and curtail profit-driven health care. I urge you to support this bill out favorably, and I have also submitted written testimony as well. Thank you very much for your time. Thank you. Congratulations.
Thank you, Madam Chairwoman, for the opportunity to address you this morning. My name is Katie Murphy, and I've been a nurse for over 40 years. I work at the Brigham and Women's Hospital in Boston and Metro West Medical Center in Natick, and I'm here in support of S683 and House 1194. You'll hear from a lot of experts today who can provide you with detailed information about how expanding the Medicare program will increase health access while saving lives and money. But I'd like to talk to you about what my fellow nurses and I see at the bedside. Every day, patients come in far more acutely ill than they would have if they had had insurance or more comprehensive insurance coverage. A diabetic whose health could have been managed through regular doctor's visits and medication ends up in the emergency department experiencing a wide range of complications from vision loss to kidney failure. An individual with high blood pressure who cannot afford his medication winds up with a complicated and expensive cardiac surgery. And hospitals are not the only facilities feeling the effects of a failing healthcare system. Untreated mental health and substance abuse conditions often land individuals in our criminal justice system. This is not the way a nation or a state should approach healthcare, which is a basic human right. Problems are not limited to those who lack insurance altogether. High copays, deductibles, and inadequate prescription coverage can have the same effect as no insurance at all. Those who are underinsured will also forego necessary care and end up in the hospital sicker than they otherwise would have been. Individuals who do eventually seek care in our hospitals, if they lack adequate insurance, can be left bankrupted by those costs associated with one adverse health incident. By instituting a Medicare for All program in Massachusetts and providing quality comprehensive health care to all, many more would seek out and receive proper preventative care and be able to afford to manage chronic conditions more effectively and diligently. In Massachusetts, our elected officials took bold steps to expand insurance to those without coverage. These actions were a good first step to ensuring all citizens of the Commonwealth have access to quality patient care. A single-payer health insurance eliminates obstacles to care and will help stabilize the budgets of local and state governments that are currently at the mercy of health insurance costs. Therefore, I urge you to report out favorably S683 and House 1194. Thank you.
Thank you. My name is Patty Healy, also a registered nurse. I worked at Brigham and Women's Hospital also for 37 years, and now I'm in another part in Western Massachusetts. It's Cooley Dickinson Hospital. And I'm going to take you at your word that you're going to read my testimony, because that's where I put all my examples in about patients and families who are suffering right now, and I know you hear those stories. So after listening today, I've changed what I'd like to talk to you about, and that is the problems that we see in our community hospitals in Western Mass. The community hospitals are really the bulk of the system for many residents. For a full, if you think of geographically of Massachusetts, a full 2/3 of the state. We have competition between partners and Bay State, and we also have freestanding community hospitals, and several hospitals have been bought out by the richest for-profit system that exists in America right now. And what we've seen is a change in the kind of health care we get. We have fewer health insurers. The health insurers are very competitive. Health New England is one of the biggest in Western Mass. It's in direct competition with the hospitals in the northern part of the state, including, excuse me, Cooley Dickinson Hospital. So a patient who comes to my emergency room, has an emergency C-section, has 2 infant twins who are premature and sick, the twins are able to move to the only neonatal ICU in the state, in that part of the state. And their care is paid for. The mother, who is in Cooley Dickinson Hospital, cannot go with her babies. She has had surgery, she requires medical care, she's this close to getting blood transfusions, but the system doesn't allow her to be transferred to another hospital. We actually were passing the hat as we were making phone calls to various charities to get money so that she didn't have to take an Uber to go back down to Springfield. She did eventually get authorization after all of our threats from our medical providers. Another incident that happens is that at Cooley Dickinson in particular is that we have also a VA. The VAs are great, but in Western Mass, the services have been drastically cut. Veterans come to the community hospital for the services they can't get at the VA. The VA supposedly pays for them. However, if a veteran needs services that can only be given at Cooley Dickinson Hospital, he or she must pay back the VA for everything for that particular episode of healthcare if they are going to access their Medicare. There are all these loopholes that happen to veterans that no one really knows until they're in that situation. Veterans have to stay, extended stays in Cooley Dickinson Hospital, because the VA closes at 4 o'clock on Friday. So if I want my patients to be able to get their medications, get their new cane and their oxygen, and go home on Thursday or Friday, I have to plan that for 2 or 3 days in advance, which we often don't know they're going to go. If not, they have to stay in the hospital at a cost to the community hospital. And for no reason at all, except that the VA won't open until 8 o'clock on Monday. And that's when they can get their prescriptions and their oxygen that they go home with. So there are so many silos that we're working with right now that some of it's in my testimony, you'll see. And I will work with, as a case manager, with sometimes up to 40 insurers in one day trying to obtain care and revenue from those insurers just to come back to my hospital so it can stay alive. So, but I know my time's up. So I obviously think that we should have a single-payer system, and I appreciate the questions that you are facing, because I don't know how to answer them either, but these silos have got to be changed, and we need equitable health care in all of our state. Thank you.
Amen. Thank you. Any questions, comments? Well, thank you very much. It's great to get these perspectives, the business perspective, the patient perspective. It's really useful. Thank you. Yep.
Good afternoon. Thank you for taking me out of order. My name is Natalie Blay. I'm the state representative for the 1st Franklin District. I'm new here, so I know we're all just getting to know each other. But I'm originally from northeastern Vermont, a really small town right on the Canadian border. And my family and I all received our health care over the border in Canada. When we got sick, we would drive about 5 minutes down the road to see our doctor, Dr. Bouchard. And we could have called him in advance, but he didn't have a receptionist, so it was hit or miss if you actually got him and were able to see if he was open to see you. So what we ended up doing was driving over, and we would pull in front of his house. His office was located on the 1st floor of his home, and if his porch light was on, he was available to see patients. And so we would look to see if that porch light was on, and we would walk up to the 1st floor of his house and walk into his reception area. And it was an honor system. You just went in as you arrived. And as Americans coming in, we paid $10 a visit. No matter what your ailment was, it was $10. He still had a sign on his wall that said, "If you can't pay, just say thanks, doc." Now, my Canadian counterparts, who lived less than 3 miles over the border from me, a border separated us, received universal single-payer health care and were able to receive free health care at point of service. Now, we were lucky. We were able to see if that porch light was on. We were able to receive health care coverage and to see Dr. Bouchard. Massachusetts right now has the opportunity to turn that porch light on for every resident of the Commonwealth of Massachusetts by advancing this legislation. During the campaign and up until now, there are really 3 things that I hear about from constituents that are top of mind for them. One of them is the Chapter 70 foundation formula and the fact that it needs to be changed to better reflect the challenges facing rural schools. The second one is climate change, and the third one is healthcare. And the bottom line is that residents of the Commonwealth should not be making decisions on their health care based upon a fear of a bill that's going to arrive in their mailbox that they cannot afford. Since 2017, 4 of the 19 communities in the 1st Franklin District have passed resolutions supporting Medicare for all. I am here today on their behalf and on behalf of all of those in the 1st Franklin District who support this legislation, and I respectfully ask that you report this bill out favorably. Thank you.
Thank you. Thank you very much.
Thank you.
Any questions or comments for the rep?
Thanks.
Thank you. Patricia Berger, Hubert Kaplan.
Thank you very much, Madam Chairs and the committee, for holding this hearing. I'm testifying in favor of H 1194 and Senate 683. My name is Dr. Patricia Berger, and I am representing the Executive Board of MassCare, the original sponsoring organization of the bill being discussed today, an act establishing Medicare for all in Massachusetts. MassCare was launched in 1994, 25 years ago, as a coalition of organizations sharing a deep concern about the inequities of our healthcare system. In 1995, MassCare sponsored the first bill to establish a single-payer healthcare system in Massachusetts. This same bill, with updates over the years, has been submitted every legislative session since. So the question is, why should this committee vote favorably for our bill now after all this time. MassCare believes that we need a better healthcare system now. We've heard a lot of testimony today from patients and friends and acquaintances who are suffering here in Massachusetts with our present healthcare system. In addition, there is looming disaster coming from Congress. They're proposing massive cuts to Medicare and Medicaid. What would we do? We need a plan here in Massachusetts in case this looming disaster occurs, and the time to do it is now. There is a groundswell for MassCare for All across the state. There is bipartisan support in the legislature, and a new single-payer caucus is actively working for the bill. In the 2018 election, at least 8 new single-payer candidates were elected to the legislature, and many more were elected to town and city governing boards. Candidates who campaigned for single-payer won their elections. In addition, MassCare has sponsored ballot questions in 36 representative districts with 100% yes votes in each district. Over 40 cities and towns have voted to endorse single-payer. And finally, MassCare has organized thousands of local single-payer meetings and events across the state to educate the voters, and we are going to continue this. So who are the voters that are fighting for Medicare for All? It's the people that have to pay ever higher health care premiums and out-of-pocket costs that devastate their personal budgets. It's the small business owners saddled with funding health insurance for their employees, making it harder for them to sustain healthy businesses. The unions that find their biggest problem with negotiations is protecting their health benefits. The towns and municipalities that balance paying for health care for their employees with funding education, fire, police, and infrastructure. And the millions, and I mean millions of people in this state who are either uninsured or underinsured and can't afford health insurance. MassCare voters need this Joint Committee on Healthcare Financing to make the difficult decisions and move the Medicare for All bill forward, because Massachusetts is a leader in healthcare. The need is here for Medicare for All, and the time is now. Thank you very much.
Thank you.
Good afternoon. I'm Dr. Hubert Kaplan, a member of the Executive Board of MassCare. I rise to speak as a medical specialist and primary care physician licensed in the Commonwealth for 60 years. I'm also a professor of medicine at Tufts and recently finished my term for many years as a trustee of the Mass Medical Society. I did start practicing before the advent of Medicare, which of course leveled the playing field for senior care to one standard. Since then, the benefits to both patients and their physicians has been a matter of record. Under our current healthcare system, we physicians find our hands are tied in doing what is best for our patients because of the controls imposed from those primarily driven by unconscionable quest for their own financial gain. I refer mainly to the insurance and pharma industries and large hospital systems. Annual profits are estimated to be $100 billion, and 40% of this is not used for direct patient care. As you all know, about 46% of our new state budget is devoted to health care. Our citizens, our cities, towns, businesses, big and small, cannot sustain this fiscal crisis. Further, our patients are being subjected to danger when their physicians cannot act in their best interest as they march to the drums of profit-seeking corporations. Ancillary issues for us physicians include prior authorization, delays, denials of care, liability concerns, and for our patients, out-of-pocket expenses, including deductibles, co-pays, co-insurance. All of these, as well as the exorbitant profit sharing, would be eliminated or greatly reduced under Medicare for All, as well as access to care and concern for pre-existing illnesses. We all have a degree of ownership in this state of affairs and need to support Senate 683 and House 1794 to show that we really care. Universal health care is a basic human right, and Medicare for All is the best way to accomplish this.
Thank you.
And then finally, I just want to call attention in late October, the Boston Medical Library will sponsor the Garland Lecture this year on transition from the current system to Medicare for All, the nuts and bolts by Dr. Summers. Thank you.
Thank you. Any questions or comments?
I have a quick question. Thank you so much for coming. So my question is, I was, the previous panel of the nurses mentioned the VA system. So in the legislation, Medicare, Medicaid would all be rolled into the Massachusetts Resident Healthcare Program. Do you see the VA being eliminated in Massachusetts as well? Because I was just confused by the previous testimony, and since you're authoring the bill, I was just curious.
No, I don't think that our bill intends to incorporate the VA. I think it's so clear that the VA has served our servicemen over the years, and it is a unique organization serving a unique population, and I think privatization of the VA system is the wrong way to go, and what it needs is to be strengthened, and I don't think our bill intends to incorporate the VA system.
And then, so one of the huge issues we're dealing with in much of the testimony is about the affordability of drugs, pharmaceutical pricing. And I'm curious as to the mechanism that this would help that, because even under Medicare, it's still a huge issue for our seniors to be able to afford medication. So how do you foresee this would help with that?
Well, the state, under our bill, the Medicare for All Act for Massachusetts, would have negotiating powers to negotiate with the drug companies, and that's how we would handle it here. Obviously, we would do better if we had a national bill that would do this nationally, because you'd have so much more clout. But we could, I mean, we're a pretty big state, and I think somebody mentioned maybe we could have a cooperative with other states near us on this. That's just another iteration of possibilities, so that we would have enough clout to really lower prices. There are other ways that the prices have to be lowered. There's all kinds of nefarious ways that the pharmaceutical industry raises the prices of drugs. They extend their there's a word for it, patents, right? There's all kinds of ways that they do it. So negotiation is certainly one way we can lower them, but there are lots of other ways that need to be done, and I think those probably will do better on a national level than what we can do here in the state.
I can make a comment about that. I think ideally it would be good to have some federal standards, because different states would look at Medicare for All in different ways. Some might use it as a weapon, and some may not. So it would be good to have federal standards, but by the same token, a step in the direction of that is to have this grassroots force to have states, maybe more liberal states, pass this bill, this type of bill, and that will induce the federal government, I think, or at least the nation, to vote for this. So it's an ongoing process, and there are many pieces to it. But the bottom line is Medicare, health care is a right, and what can we do to accomplish this? And of course, the figures that we talked about are unsustainable. And it isn't that we have the best system in the world, the best healthcare system, no way, nor the longest longevity, no way. And it's a wake-up call. This is the time for action. Thank you.
Thank you. Thank you very much. Senator Sear. Thank you, everyone, for your patience. We appreciate it, and we're glad to see you.
It's good to see all of you too. And I'm with the panel in spirit today, but flitting about the State House. We have a number of hearings and briefings. But I wanted to briefly come and speak to you, Chair Friedman, and you, Chair Benson, and fellow members of the committee, and testify in support of Senate Bill 674, an act to ensure effective health care as a right. So this legislation would allow the Commonwealth to study and collect data regarding the potential for a single-payer healthcare system, which I know you're hearing a lot about today. Currently, Massachusetts spends more on healthcare than any other state in the nation. In 2017, that figure was $61.1 billion statewide. Premiums for both families and individuals and employers have increased by 12% in the last 5 years, while benefits have either decreased or at best remained the same. This has been particularly burdensome on middle-class families and on the self-insured who make too much money to qualify for public plans but don't have the benefit of large commercial-scale insurance. Health insurance has also become a major cost driver for employers, arguably one of a large factor in the plateauing of wages that we've seen. And the elevated healthcare costs that we have don't necessarily translate to increased access to high-quality care, particularly when we consider social determinants of health and geographically isolated communities. And indeed, we have a fragmented healthcare system that we currently have today that places burden on providers and on our state's economy while leading patients to feel unsure about their care and what they can afford. And I mentioned those significant healthcare disparities continue to plague a state that spends more on healthcare than anyone else and arguably has really great healthcare services. And so our current privatized and subsidized healthcare system, really merits some thorough vetting and examination, and you're hearing that today. What Senate Bill 674 does, it does not guarantee implementation of a single-payer system, but will allow us to study what this type of system would look like or could look like in the Commonwealth. And so the first step to understanding a single-payer system in Massachusetts is to gather data to determine what's feasible. So if passed, this bill would require CHIA, the Center for Health Information and Analysis, to produce a report comparing a single-payer benchmark with actual healthcare spending in the state over a series of years. If after several years that single-payer benchmark is actually proved to be actually outperformed our actual healthcare spending, then the Health Policy Commission would be responsible for working with CHIA and using this data to develop a single-payer healthcare implementation plan and submit it to the legislature, to us for consideration. As healthcare costs continue to consume a larger percentage of everyone's budgets, whether it be families, whether it be businesses, whether it be the Commonwealth's, it's crucial that we start to consider alternative solutions that address affordability and continue quality of care. And this bill implements an evidence-based approach to healthcare payment changes, and it's an approach that has broad support. Actually, this is an approach that the legislature, the Senate, when we took up a payment reform bill in 2017, we actually included this as part of that. And so action, I'll close by saying action on this bill would demonstrate meaningful progress on an issue that many, many constituents, many, many employers, many, many families would like us to advance and address. And as a longtime leader in healthcare reform, I believe this bill would put Massachusetts squarely in the national conversation on single payer with a methodical roadmap to seriously consider the issue before us, which is a profoundly complicated one. Thank you for the consideration of the legislation.
Quick question. Remind me, is it a 5-year study?
So the current bill is drafted. Actually, the Senate passed last in 2017 was 3-year. This bill is 5 years.
5 years.
I think I would really, ask the committee to look at sort of a timeline that makes sense. We probably want to get a significant amount of data here. I was remarking to my colleagues when I came down here that I forgot my token rubber band ball that I have on my desk, which is the analogy that I use to really describe how complicated our healthcare system is. And as we've layered and layered and layered and layered onto that system, I think it's really disingenuous to come in here and say, oh, well, let's move to a single-payer system tomorrow. It's just not. It's not the world we've built for ourselves. And so to peel back that proverbial rubber band ball, I think we'll have to seriously look at timeline implementation.
And we would include everything, including pharmaceuticals. And
yes.
Okay. Thank you, Chair.
Thank you. Thank you so much for filing this bill again. And as you know, I was the House sponsor of this legislation. I love this bill primarily because I'm a data nerd, and I think it's great to gather all this information. But I will say, and I'm wondering how you are addressing this, my issue was as you look at the bill and implementing the bill, the question then to me became, what are you comparing it to? Single payer could mean many different things, and we know throughout the world there are many different types and models for this. And without actually developing the model, I felt like I couldn't intellectually make the argument about the data collection because we don't have a model that we're spelling out. And so it could be used in a very nefarious way to create a very expensive model that we could never, that sort of thing. So I'm wondering what your vision is, how that model would be created, and how do we ensure that it's not being used as an argument against single payer from the outset?
Yeah, so first, forgive me, I should have recognized you for your leadership on this as well, and as a partner in crime in this bill. And it's even better when the filer of the bill ends up the House chair of the committee. So I think this is a really important point. And in the bill that we had filed last session and also this session, there are some provisions around the criteria that are used. I tend to agree that I think that this committee really should take a look at really strengthening that language and being more prescriptive of all the pieces that we're going to look at. I think you're right. If we just cast too broad of a net without much direction, one, from an implementation perspective, CHIA is going to spend a lot of time just scratching their heads. I think to the point about you could easily create a model that would show that it's profoundly more expensive. And then 3, how do you capture savings from, which is essentially a shift of cost in the system, right? From employers and employees, looking at how that's shifted. I think that's really important. I think we've got to sink our teeth into this, though, in the committee and specifically spell out that. I had actually tried to work, and we worked to strengthen the bill a little bit when we refiled it. I'll admit that it's not as strong as I would like it to be, and so this is why we have this great committee process, right, where we can sink our teeth into things, we can strengthen it. I think certainly, you were mentioning prescription drugs. What would it mean if the Commonwealth is the payer for healthcare, right? You have one entity. What does that mean from a negotiation perspective on what those costs are? Would we see significant savings there, right? We need to bake that into the model, and so on and so forth. But as I've said, this is a profoundly complicated system, and so I think I'm excited to have this bill before this committee. As a member of the committee, I'm hoping to work on this bill and to enhance the prescriptive portions of this around what the benchmark actually looks like, and then also the transition to the trigger for the Health Policy Commission to begin to provide a plan. Maybe we should actually have the Health Policy Commission be working more directly on the data collection component of it. This certainly, I think, can be strengthened. But what I really like about this bill is it's really honest about what it actually will take to move to a single payer system, and that because we have such a profoundly complicated system with multiple payers, yes, the public payer actually being the largest payer currently in our system, but also with state contributions, federal contributions, private employers, individuals, this is going to be a lot of work to unravel that rubber, or not unravel, to pull apart and to reconfigure that rubber band ball into I haven't figured out the analogy for what the rubber band ball should turn into, but I'll work on that, and then hopefully when we get this out of committee, we can take this up on the floor. I'll have a better analogy for you.
Thank you. Any other questions or comments? Seeing none, thank you very much.
Thank you for your time.
Mats Holmquist.
I'm Mats Holmquist, and thank you for giving the opportunity to speak here. I'm representing our Revolution Malden, and I think I think we've heard a lot today, and it's very clear where we want to move and how we want to do that. And I just want you to consider to be the leader, that we can be the leader in Massachusetts to do it again. Thank you so much.
Thank you,
for
Mats.
For Medicare for All.
Thank you. Patricia Healy, I think we heard from Patricia. Right, thank you. Sophia Salas, Susanna Daggett, and Nathaniel Meyer. It's okay, listen, you waited for us, we can wait for you for a minute. Take your time.
Hi, good afternoon. My name is Sophie Salas.
I'm Susanna Daggett.
Nathaniel Meyer.
And the three of us all live in the Boston area and just finished our first year at Tufts Medical School, where we are also members of the Tufts Students for a National Health Program, or SNAP, and we're here representing dozens of our classmates who are also part of that group. Thank you to the chairs, vice chairs, and all the members for letting us talk today and having this hearing. We're very grateful for the opportunity to provide testimony in support of the life-saving piece of legislation that is H 1194 and S 683. We'd like to take this time to sort of give you a little glimpse of how we as future healthcare providers are being trained and how that's showing us just how crucial this bill really is. So throughout my first year of medical school, I've apprenticed in various offices across the healthcare spectrum. I've been in primary care, where I've seen people come in for their annual physical, and I've been in the hospital treating patients who just had a kidney transplant. In nearly every interaction, people talk more and are more worried about the healthcare costs than about their actual healthcare, despite being insured publicly or privately. I've had the ability, I've been privy to a lot of intimate and really difficult decision-making processes that many people go through each time they see a doctor. They ask questions like, which of these several needed appointments should I keep? Which of my prescriptions can I fill this month? And which of my health problems can I leave untreated a little bit longer? And these aren't questions that people should have to ask. I've met with one woman who was 51 in Newton, and she hadn't had a mammogram in 5 years because she was still paying off her previous mammogram, despite being on her husband's insurance. I spoke with a man who was 64, and he was from Malden, and he was taking his hypertension prescription at a lower than prescribed dose to make it last longer. I also met with a woman here in Chinatown who was 28, and she was afraid to get her blood work completed to check her thyroid because she was scared what the potential cost might be. And no one should not seek out medical care because they are afraid to use our system. Physicians now are forced to prioritize costs over the evidence-based gold standard treatments. And as a future physician, I'm very discouraged by the lack of high-quality, comprehensive, and accessible health coverage when we live with so much wealth and so many resources at our fingertips. We can and we must do better.
Hi, I'm Susanna. I'm a future primary care doctor. And I'm sure you're all familiar with the data that the U.S. is going to be short almost 50,000 primary care providers in the next 10 years. And despite this really desperate need, almost every doctor that I've worked with this year has warned me not to go into primary care. They bring up the burdens our current system puts on PCPs, endless paperwork, short visits, and just the constant need to fight with insurance companies all day instead of taking care of their patients. And most disheartening are a few conversations I've had with PCPs who've worked in the field for 30 or 40 years and tell me that they wouldn't make the same decision had they known what their job would entail today. So 1 year into medical school, I'm still young and naive to many of these burdens, but I've watched peers and mentors burn out on bureaucracy and lose sight of what inspired them to choose medicine in the first place. And this future scares me, and it makes me waver in my decision to choose primary care. So today you've heard from a lot of patients whose lives would be improved by these bills, but Medicare for All is a healthcare workforce issue too. Our current system isn't working for anyone, patients, doctors, nurses, and it's not sustainable. We can't continue to expect people to choose this profession in a system that favors profits over patients.
I'm Nathaniel, and I'd like to give you a sense of what we're learning in medical school and what we're not learning. So we have physical diagnosis class where we're learning what to listen for in the heart and lungs and how to systematically examine patients to identify pathology. It's a place where we get practice doing tricky things like fundoscopic eye exams. We dissect the bodies of generous donors to learn human anatomy. And we spend time in hospitals and clinics learning how to run visits with patients and document everything, symptoms, medical history, exam findings, assessments plans. All in all, it's a pretty good start at how to be the kind of doctor that we all think of when we hear the word doctor. But here's what we're not learning. We're not learning how to write notes that will prevent a patient's insurance from refusing to cover their medications. We're not learning how to tailor a treatment plan so it's affordable for a patient with a particular insurance, whether they're uninsured, underinsured, badly insured, or extra platinum insured. Plans are way too numerous and complex to even consider the possibility of learning how to do that. We don't know how to prevent our patients from going bankrupt from medical bills or from skipping pills. And we have no idea how to explain to our patients the most strategic way to run a GoFundMe campaign online. So are the three of us going to be prepared to be the PCP for your sister, your neighbor, and your bus driver and 2,000 other patients? Absolutely not, because we're about to enter a system that makes it literally impossible, no matter how much training we have, to provide quality health care for all of our patients. So for folks who are not supporting this bill are in denial. By the time we graduate, if improved Medicare for All isn't Massachusetts law, it's going to be a tragedy. And look, I get that it's hard and that it can feel complex because it is, but it's also simple. People don't have to sign up for at the fire department and pay a premium before they call 911 for a house fire. You just get that for being part of society. And there's no good reason that healthcare isn't the same way. As future physicians, we want to do everything we can to help our patients live their best, healthiest lives. And with improved Medicare for All in Massachusetts, we will reach that goal. So thanks so much for your time and for the hearing.
Thank you very much for your time. That was a great testimony, and you're going to submit it to us?
Sure.
Great. Are there any questions? Comments? Great. Thanks so much, and thanks for your patience. Gail Garrett. Gail Garrett.
Oh, there she is.
Afternoon. I'm here in support of Medicare for All. I come from the tiny town of Mount Washington, Massachusetts. Drove a good 3.5 hours to get here. It was a last-minute decision, so bear with me on my presentation. I apologize. It's a very tiny town. We have only about 146 residents. I'm really proud that our budget keeps going down, despite all the rules and regulations, mostly coming from the state. Our budget, all said and done, annually is about $800,000. If the town paid 100% of the health insurance for its employees, which are few, we'd be paying $150,000 a year. $150,000 out of $800,000. That's about 19%. Our town doesn't pay 100% for its employees. We pay 50%. So 50% is $12,000 a year for the employee. An employee making $52,000 a year is paying $12,000 to Blue Cross. Almost a quarter of his salary. 1 week's pay. It's outrageous. I can't urge you enough to act quickly. It's killing working people. It's killing me and my husband. People are working just for health insurance. That number is outrageous. The town is paying almost $24,000 a year per employee for a family plan. So for a person making, again, on our highway department, $52,000 a year or so, and that's not including his overtime and everything, that's huge. So we're in essence paying him $76,000 to work on our roads. It's huge. I can't emphasize enough how important it is to get this moving and get it done. It's killing working people. We are working for Blue Cross. And I don't understand why it is that the numerous insurance companies and insurance groups are making millions, and we think we can't do it. I'm really surprised. A gentleman asked earlier the percentages and the numbers. So on a $52,000 salary, this guy is paying $12,000 a year. At the 2.5%, that would be $1,300 a year. I cannot believe between the towns and the school districts and the state, with all we're paying, the working people are paying, that we can't do this financially. I don't understand why we can't just simply expand Mass Health. So for the last couple of years, 2 or 3 years, I've asked our town at our annual town meeting to pass a resolution, and I'll read that to you. It says, and it was passed, by the way,
Actually, can you give it to us?
Absolutely. It's
Okay,
on our
why don't-
website,
why don't you-
www.townofmountwashington.com.
Why don't you give it to us, and you don't have to read
I'll
it.
email it to you.
That would
Can
be
I
great,
do that?
yeah. And yeah,
As I
just
kind of
send
marked
it.
this one up, and my whole presentation changed based on what I was hearing,
Sure.
really.
I'm
But it was
cognizant of
approved
the
for the last
time.
several years unanimously. Granted, everyone doesn't show up at a town meeting.
Yeah.
But I've asked for this on each town because we wanted to urge our state legislators to act, and to act sooner rather than later. It is killing us.
Thank you.
I know other neighbors that are working just for health insurance. The resolution is to see if the town will vote to declare that the town of Mount Washington believes that health insurance costs for towns, its employees, and others have become untenable, that the town supports a properly and efficiently designed state single-payer system, and the town calls upon the state legislature to adopt a proper and efficient single-payer system in Massachusetts at its earliest possible convenience, a system which will hopefully use the state administration already in place for Mass Health, and a system into which all residents and entities contribute fairly. Passed unanimously.
Okay,
That's
thank
all.
you.
Thank you.
Any questions? Thank you.
Thanks.
Matthew Miller? Cable Ames.
Hi, thank you very much. I want to also thank everybody that's come up here and told personal stories, because it's not easy to do, and we don't really want to be here doing it, but we feel that we have to. I'm here in support of H 1194, Senate Bill 683. In 1982, my mother was diagnosed with multiple sclerosis, and I was 10 years old. I then became her advocate and caretaker. And it was then that I realized the mess and the bias of the healthcare system. I wish that I could say that I managed and met every challenge, but I did not. It was a decades-long battle that ended in defeat, because after all that, in 2013, my mother died without health care. In 2012, she was eligible for a portion of my father's SSI and ended up making $22 more than Medicaid would allow. She obviously could not afford health care, so 9 months later, she passed away. I don't want anybody to have to lose a parent or a loved one because they don't have health insurance and they can't afford it. And I don't want anyone's childhood to be hijacked because of a complicated healthcare system. I urge you to save lives, and I urge you to view this bill favorably. Thank you.
Thank you. Thank you for sharing the story. Norman Doust.
I'm here to testify in favor of House 1194 and Senate 683. My name is Norman Doust. I live in Cambridge and have spent the vast majority of the last 35 of my working years in the healthcare field. I worked for a vendor, McLean Hospital, Dana-Farber Cancer Institute, Mass General, and Brigham and Women's. And as a consultant, I've worked for projects for the Center for Disease Control and Prevention, the Veterans Health Administration, and a Massachusetts healthcare provider network. I'm going to testify in one small area that these bills would decrease costs for hospitals. Someone asked earlier about reimbursement for hospitals. So it will save hospitals money. My most recent project was 13 months. I was working for a Massachusetts healthcare provider network of 3 hospitals and multiple physicians network. The goal was to collect all of their patients' data into one spot so they could do appropriate care management. Things such as checking on all their patients with diabetes to make certain they've had renewed their prescriptions and things like that. So the physicians and the nurses were the people that would look at that data and do that. So I spent about 13 months working on that project with several of their employees. And what we had to do was collect all the data for their patients into one spot, which seems like a simple process. So their electronic healthcare record, EHR vendor, made it easy. They provided a spot for that, and for all of the data that come from the patients in their hospitals, they provided all of that. However, the patients had treatments outside of their hospitals. They had prescriptions filled in local pharmacies. So for their Medicare patients, that was easy as well, because Medicare provided all of that data in their vendor, national healthcare vendor, had to do this for all their hospitals, and they provided all of that. Our task was to deal with the 15 or so other insurance companies. Unfortunately, those were all different formats, and to make a long story short, in the 13 months that I spent with the other folks, we managed to do it for just 3 insurance companies. Now, if there were this bill were to pass, that hospital system their vendor would support all of that. They would get their data in a single format, and all of the effort would not be needed to just get the data in. Instead, they could provide care provisions. So, and I don't have enough time to talk about the amount of savings and time and effort for producing bills and collecting insurance.
No, but if you have
Thank you.
written testimony, please give it to us. That would
I
be
will
great
do
when
that.
we look
Yep.
at it. Yes.
So I encourage you to vote this out favorably. Thank you for your time.
Thank you for your time. Oh, Provost?
Good afternoon, gentle committee chairs and members, and for your patience and fortitude. I know you started early this morning. I'm Denise Provo. I represent a district in Somerville. I do not pretend to be a healthcare expert, but I have made a lot of observations of our healthcare system as a patient and parent and child of aging parents. I also have a lot of family and friends in Canada and in Great Britain, all of whom are incredulous that I live in a country with my family, was also their family, that's sort of among developed nations is the Wild West of healthcare, where it's kind of like a lottery, whether you're covered, whether you have a policy that's going to have deductible and copay levels that will bankrupt you under the wrong circumstances. And I'm convinced that it does not have to be this way, because many countries have figured out how to cover their populations for needed health care and preventive care. And that doing so has a lot of additional benefits. For instance, a unified set of health data that allows countries to track and understand community health better than we do with our fragmented system. You know, in England back in the 80s, they figured out how much higher a percentage of the increase of obesity in their population was going to bankrupt the National Health Service, which allowed them to move nationally and in a uniform way into an anti-obesity campaign, which has helped, and of course, which secondarily helps with type 2 diabetes and high blood pressure. There are so many benefits to having a unified health system. And I see so many inefficiencies from how fractured our healthcare system is. You know, I open my mail and I have this is not a bill statements, which have become a ritual. You know, I have to take out the first page and shred it, and then I have an envelope and a thick stack of paper. These are explanation of benefit mailings, which come in piles. You know, every time there is you get a service from a healthcare provider and there is a billing. Plus, there's all this crazy back and forth where bills are submitted to the insurer and then they come back again, and all of these people who are doing this paperwork, or many of them, could be trained to be direct care providers. They could be community health workers, they could be health educators, they could be doing so many things which improves the health of people in our communities much more directly than our crazy lottery of insurance with its bizarre billing system, which is a lot like playing musical chairs, where you don't want to be the payer who's on the line when one of your insureds has to have some kind of procedure or ambulance ride or any other covered service. I think you get the drift of my my testimony. I thank you for listening at this late hour. I'm happy to take any questions with a caveat that I don't have all these details figured out, but I know a lot of very smart people in the state, from John McDonough to Don Berwick, have thought long and hard about how to do this, and I think we've got the expertise to work it out. Thanks very much.
Thank you very much. Thank you, Rep. Nellie Taylor.
Good afternoon. My name is Nellie Taylor. I use she, her, hers pronouns. I'm rising in support of H1194 and S683. I live in Florence. I've been a math teacher at East Hampton High School since 2008, and I'm the president of the East Hampton Education Association. I'm the insurance subscriber for my 7-year-old son, my ex-wife, and myself. As a president of our union, I've worked extensively on issues related to the health insurance of the city of East Hampton that the city purchases through the Hampshire County Group Insurance Trust. It's arguably one of the best plans offered to municipal employees in the state. In the fall 2018, the trust began coaching municipalities to pass MGL Chapter 32B, Section 21 and 22, which strips collective bargaining rights from public sector labor unions around health insurance. I spent no fewer than 30 hours in meetings, some of which I had to incur childcare costs to attend, in addition to over 20 hours doing additional organizing work, educating my workers, my members, my community, and about why this law is unnecessary and why it's bad for the unions and the city workers. Through that process, meeting with city officials, consultants, and other union representatives, it was clear to me that the rising costs of insuring municipal workers, combined with inadequate Chapter 70 and Chapter 90 funding, are resulting in a destabilization of the East Hampton city budget, and I would add the budgets of all other municipalities in the Commonwealth. I just kept thinking, like, a single-payer system would have eliminated the need for spending all of this personal and city time and money figuring out how to bargain health insurance. So educator salaries in East Hampton have not kept up with the cost of inflation for over a decade, and yet the cost of our health insurance premiums have steadily increased. As of July 1st, 2019, our out-of-pocket costs will jump significantly. We are becoming functionally poorer because increased health insurance costs are eating the small raises that we do get. I have members who work for the privileges of purchasing this health insurance for their families, even though it results in them taking home less than $200 in a 2-week pay period. Insuring educators is a major part of the already insufficient Chapter 70 funding from the Commonwealth. Medicare for All would free up that funding to provide services directly to my students. In early May, I did a 20-minute focus group with my calculus students, AP Calculus. They know what's going on. I asked them, you're about to graduate. What do you need that you have not gotten in your East Hampton education because of funding? And they told me, they wish they had a full-time librarian at every school. They wish that their libraries were open before and after school. They wish for after-school tutoring. They want a late bus so that poor students or students who don't have rides because their parents both work can attend extracurricular sports, clubs, and get extra help from academic teachers. They want more school guidance counselors and school adjustment counselors. They want broadcasting classes and interfacing with the community media. And I would add to that list, we need fully staffed nursing offices with RNs in them. We need appropriate levels of custodial staffing. We need autism and behavioral specialists in every single building all day long. All of this and more would be covered by the cost of insuring educators that is currently spent out of Chapter 70 funding. A single-payer system would provide financial security and stability to municipal employees, some of whom now work 2 or 3 jobs in order to make ends meet. It's essential that the Commonwealth of Massachusetts lead the nation on solving the healthcare crisis by implementing Medicare for all.
Thank you. You paint a very compelling picture, so thank you for your testimony, and I hope you're going to submit it.
I will.
Thank you.
Thank you.
Any questions? Thank you. Oh, Rep. Balzer.
Thank you, Madam Chair, for taking me out of turn. I will be brief. I know I'm guessing you've had a long hearing. I'm here to speak in support of House Bill 1126, an act to ensure affordable health care connector coverage. This is actually a very simple bill. It just codifies and puts into statute what is really the current practice of the Connector Care program. It's to protect the lowest income residents who are on Connector Care and make sure that there's a no-cost health care or premium available to them. That is the current practice, but it's not in statute. Years ago, it actually was in statute in our original Uniform Health Care Act. When the Affordable Care Act got mixed in, some of the language disappeared. And this is really just about making sure that what the connector has done, they'll continue to do, and also bring some transparency to the Commonwealth Care Trust Fund, just to make sure that we know where this money is going and to make sure that there's enough money to protect our low-income residents. So I hope the committee would look favorably on this bill.
Great, thank you. Any questions? No, thank you so much. Sarah Weinberger?
Afternoon.
Hi.
Thank you, committee chairs Friedman, Benson, and the members of the Healthcare Financing Committee for giving me the opportunity to share my remarks in support of an act establishing Medicare for all in Massachusetts. My name is Sarah Weinberger, and I'm Professor Emerita of Social Work at Western New England University and Chair of the East Hampton Hub of Medicare for All. Access to health care should be a basic human right for every society. Yet, in Massachusetts, according to a report last November from the Georgetown Center for Children and Families, the Commonwealth saw its percentage of uninsured children increase from 1% in 2016 to 1.5% in 2017. While Massachusetts' percentage of uninsured people at 2.7% is the lowest in the U.S., according to U.S. Census figures, that still means that 186,358 human beings are living in Massachusetts without health insurance. And that doesn't include those who are underinsured and living one illness away from financial disaster. I've been spending the last year and a half assisting a Congolese refugee family who relocated to Northampton last year. After being here for more than a year, many people would say they are living the American dream. There's a father, a mother, and their 6-year-old son. The father's employed, who used to be a teacher, is employed full-time at a grocery store and is making what is considered a living wage of $15 an hour. He pays for health care insurance for his family through his job. This father did fulfill the dream, he thinks, of getting off of public assistance in less than a year. But when he recently had to undergo eye surgery, he was shocked to get a bill for $1,500. That was because the copay that the family had on their policy of $3,000 they had not yet met their deductible. Not copay. They had not yet met their deductible of $3,000. He could not understand why he would have to pay this kind of money when he had health insurance that he was paying a lot of money for. For those without savings who are barely getting by, coming up with $1,500 can be an overwhelming challenge, yet he is clearly not alone. Many years ago, when my mother was diagnosed with pancreatic cancer in her early 60s, I discovered that she was grossly underinsured. As she was dying and I was grieving, I found myself fielding phone calls from creditors who threatened to take her home and every cent that she had left. My mother lost her battle with cancer, but I am determined not to lose the battle for affordable, accessible health care coverage for every person in the Commonwealth. When my daughter and I traveled to Germany in 2014, after her graduation from college, she sought service from a healthcare provider in Germany when she came down with an upper respiratory infection. After exam, she asked how much she owed for the visit. The doctor said, "Consider it a gift from the German government." I can't imagine that happening here. It's appalling that the cost of healthcare is such a burden for so many. For as long as I can remember, every year, a new Medicare for All bill dies before it ever leaves this committee. Last November, 76% of those who voted in East Hampton voted in favor of a non-binding ballot question in support of Medicare for All. I am urging the members of this committee to act boldly and vote this bill, report favorably this bill out of committee so that it can be so that it can be debated in the legislature.
Thank you. Thank you. Thank you for your testimony, and I hope you'll submit the written portion. Deborah Levinson?
Good afternoon, and thank you for hearing these comments. I'm testifying in favor of an act establishing Medicare for All in Massachusetts. My name is Deborah Levinson. I live in Hadley, and I am the co-convener of Western Mass Medicare for All, which is a regional network of groups. We are calling them hubs, organizing for single-payer health care in Massachusetts. Our intention is to establish hubs in every state representative district, a strategy that has now also been adopted by the statewide MassCare Coalition. In Western Mass, our hubs conduct frequent public education events, host and participate in public forums, lobby local legislators, canvass door-to-door, and much more. Last November, we ran a non-binding ballot question for single payer in 6 legislative districts. It garnered an overall yes vote of 77% across the 6 districts. Perhaps most significant is that the question won everywhere that it appeared, not only in the most liberal towns, but also in rural areas and more conservative locations. We are also working at the municipal level to pass Medicare for All resolutions and to show the impressive savings for towns and school districts under single payer compared with current expenditures. You may think that general audiences would be uninterested in the details of healthcare financing, but in our experience, they are eager to discuss it. People are hurting and they're scared. We respond to many questions about Medicare for All, but today I actually have a couple of questions for you. We are often asked, how will we pay for Medicare for All? How can we afford it? The proposed financing for single payer is described in the legislation under discussion today. But a question I have for you is this: how will you pay for health care if we do not adopt a single payer system? It is no secret that rising health care costs are stressing state, municipal, school district, business, and household budgets. Nearly 200,000 people in Massachusetts, as you know, have no insurance at all, and increasing numbers are underinsured, unable to even access health care because of high out-of-pocket costs. Massachusetts is one of the most unequal states in the country in terms of income, and our current healthcare financing system exacerbates and intensifies that inequality. So another question I have for you is this: what is the advantage to the people of the Commonwealth of Massachusetts of preventing open consideration of these bills by the full legislature? As Senator Friedman said earlier, we need transparency about this issue. How would allowing these bills to die in committee again serve the goal of transparency? I asked for a favorable report out on S683 and H1194. I also, if you'll allow me, I just want to take a few more sentences to speak out against Representative Hogan's bill. I sincerely hope that you will not mock the huge and growing number of single-payer supporters in Massachusetts by advancing that bill. The bill proposes a commission to study single-payer that is patently biased against single-payer. Thank you for your attention to these remarks. Many of us will be following this committee's work with interest and the disposition of these bills. Thank you.
Thank you very much. Is Shane Leakey?
Hello, and thank you for having me today. My name is Ihsan Leakey, and I'm here to testify for House Bill 1194, Medicare for All. I use she, her, and hers pronouns. I'm here as a member of the Our Revolution Mass Women of Color Caucus. I was born and raised in Morocco, North Africa, to a mother who was a farmer and a father who was a teacher, a typical working family. When I was 13, I lost my father to stroke. He was gone within 2 days. And I later learned from my mother that we could not afford to pay for his heart condition. And that because of that, the stroke happened. And it happened too quickly that there was no available hospital to save him right away. When I was 20, I came to the United States. I was very excited, all about the American dream. I had heard from people in my family who live in France that they had access to all sorts of health care, either from giving birth or from just getting sick, and they don't have to worry about co-pays or about anything. So I expected that that would be here in the US as well. However, the reality was different. When I got here, I was priced out of birth control. It was $60 for a pack, and I was only working for $5 an hour babysitting twins. Then I needed dental surgery. And I was told that dental care is only for the wealthy in this country. So I presented myself at a dentist, and I was refused because I didn't have the health care that would cover that. I went to a hospital. It's not even a hospital. It was like an industry hall where a bunch of dentists were doing some pro bono work. This is in America, by the way. I sat at the chair, and I looked over the little platter where they have all the dentist tools, and there was rust on the platter. So I got up and left, with the pain still wrenching me. Later, I had a child. My daughter is now 7. Her name is Nora. And after I had her, just like any mother, I had postpartum depression. So I needed access to mental health care. And that, again, was only available for the wealthy, because a $100 copay is not something that I could afford. Then I got into a car accident. And the first thing I said, please do not call the emergencies. Please do not call the ER. And you know why that is? Because I knew there's going to be a $6,000 bill at my door right after. Because I knew that even if I go to the ER, I'm going to have to wait for 6 hours before I'll be seen. Now, these are issues that I have, survived in my life. And I am at a place where, I can now afford the mental health, and I can, afford to take care of my PTSD as a survivor of sexual assault and abuse, and I can take care of dental work. I could even go and get veneers if I wanted to, right? But I would tell you that when my husband's work insurance plan changed, I went to a doctor and I was refused. It doesn't matter in this country how poor you are or how wealthy you are when it comes to health care. It's a human right, and unless we have it, all of us, it's not gonna work. If you target what level of wealth you're gonna have, it's not gonna work. You're always gonna have people fighting it back. We cannot afford to lose any more lives to the greed of the health insurance and pharma companies. I support Medicare for All as a single-payer system. It is our moral duty to ensure that all the people in this country have the right to health care. And that starts right here in the Commonwealth of Massachusetts.
Thank you.
Thank you.
Thank you. Any questions? Stephanie Strand.
Good afternoon. I'm from the town of South Hadley, home of Mount Holyoke College. Go Mary Lions. Last November, we had a ballot question, a non-binding ballot question also, called Question 4, and it asked our voters, do you support single-payer health care in Massachusetts? And it passed. Over 65% of our residents said yes, which was a little surprising. South Hadley isn't some hotbed of liberalism. It's just a regular community with as many conservatives as liberals, as progressives, as many, I hate to say it, Yankee fans as Red Sox fans, oddly. And then a month ago at our town meeting, as a follow-up, we proposed a resolution supporting specifically House 1194 and S683 to our town meeting. And 68% of our town meeting members voted yes. I was floored. I did not expect that outcome, and I was the one proposing it. I thought, I'll just get the conversation going. 68% voted yes. That is telling us something. The voters want single payer to be seriously considered by our legislators. Seriously considered. Now, related to this, South Hadley's been in the news because a budget shortfall was just announced in our schools, an almost $1 million budget shortfall. And our South Hadley High School students have been in a furious letter-writing campaign, writing letters to Beacon Hill, asking for money, begging for money, because teachers are being laid off, staff is being laid off, art programs are being canceled, and phys ed programs are being canceled. Now, there are a few things driving this budget crisis, and one of them is, yes, there were some contractual salary increases that had to happen, and also there were increases in special ed, like everywhere, right? But this is crucial to know. Healthcare employee costs, the cost for our town to cover our employees for health care, has gone up an average of 7% per year for the past 10 years. This is untenable. Our town can't keep going like this. What's the next thing that we're going to cut? What's the next program? What's the next teacher who's going to get fired? What's going to happen with our seniors? What's going to happen with our at-risk youth? And this is just one town, and we're not unique. Now, I just want to give you a couple numbers. This past year, our town paid $2.9 million for health care coverage for town employees. Under H1194 S683, we would be paying $1.1 million. In other words, $1.8 million yet less per year to cover our health care for our employees. There's our budget shortfall right there, right? $1.8 million per year. And again, we're just one town. Imagine if every municipality in our state had those sorts of savings. I want to just say one more thing briefly. I know you have so many bills to read, and I know your eyes must be bleeding by the end of the day, but I do hope you'll give this bill a very careful read before voting it favorably out of committee, because the question of out-of-state employees is covered in the bill. If they work 20 hours or more in the state, they are under the plan. And the question of what happens to Massachusetts residents who are injured out of state is covered in the bill. And I made a little slideshow to make the bill, break the bill down, that I've shared with many people. And in addition to our resolution, I'm going to share it with you. And it's just a little cheat sheet, and you might find it useful. Thank you so much for your time. I appreciate it.
Thank you. Nancy Stenberg.
Sorry. Hi, my name is Nancy Stenberg. I live in East Hampton. I get to hang out with Nellie. So I am one of the public school librarians she was referring to who lost their job and was forced into retirement at the delicate young age of 55. Because I lost my job and then tried to get another job and then decided to take my retirement because it was just sitting there. Why not? I was denied health care from the system that, told me to leave. So, Mass Health. Now, because I am still young and sporting this lovely hair that Senator Friedman and I share, I still have to work because that pension is not enough to live on. So, Mass Health, get a job, but I refuse to become a widget in a factory just to have insurance. So, got a job as an organizer, but it didn't last forever. So Mass Health, private insurance, Mass Health. So here's what happens to me when I switch back and forth. I have asthma. So Mass Health says I have to have this inhaler, but the private insurance says I can have, a fancy inhaler. That's not good for an asthmatic. I also have sleep apnea, so I have to switch from one supply company to another. Out in Western Mass, there's only one CPAP supply company. Mass Health says you can only choose from 3 across the state. So to go through that process takes 6 weeks. So then I'm behind on getting my supplies. That's not good. I can't go to my preferred dentist when I'm on Mass Health, so I just don't go to the dentist. I can't go to a dermatologist. As you can see, I have this lovely Irish skin. Not good. So these are things that would not happen if we had Medicare for all. I just get to go to the same doctors all the time. I wouldn't have to worry about this stuff. Now, you might think, she's of a certain age. It's only going to happen to her. This is happening increasingly to everybody in our gig economy because a lot of people in the millennials, the Gen X, they just go from job to job. And if we had Medicare for all, this would not happen. So I'm telling you, let's do this. Okay, and it will save us money. So please, let's pass an act establishing Medicare for all in Massachusetts. Thank you very much.
Thank you very much. Ann Roy? Thank you.
Good afternoon. Does anybody ever stand? Should I sit or stand? Thank you. Stand. Good afternoon. My name is Ann Roy. I live in Southampton, the far, far West. I'm a professor of social work at Springfield College. I'm here today to urge you to report HB 1194 and S 683 favorably out of committee. Our beloved Roosevelt was a driving force behind the 1948 Declaration of Human Rights. Article 25 speaks directly to the right to receive medical care, the cause for which we stand before you today. I will now quote relevant sections of Article 25. Everyone has the right to a standard of living adequate for the health and well-being of himself and his family, including food, clothing, housing, medical care, necessary social services, and the right to security in the event of unemployment and sickness. Motherhood and childhood are entitled to special care and assistance. This is the premise and the principle of many of the world's industrialized nations with whom we compare ourselves favorably. The following is a case in point. It well illustrates how America must do better for its young people. Last fall, I had a young Hispanic woman in my policy class. I had recently seen that she had become very quiet and had a face both troubled and anguished. One day after class, I approached her. She broke down in tears and told me, "I'm trying to gut out a UTI. I'm in a lot of pain, and I don't have to go to a doctor." This was now an emergency. We immediately took her to the college infirmary. Subsequently, this young woman was hospitalized for an untreated UTI, a common and easily cured infection when treated early. Left untreated, it can kill. In the name of social justice, equity, and compassion for women, young women with untenable choices, I urge you to report these bills favorably out of committee. And thank you for your time today.
Thank you very much.
You're welcome.
Llewellyn Lambros.
Hi, good afternoon. I'm here in support of Senate Bill 683 and House Bill 1194, Medicare for All. My name is Llewellyn Lambros. I'm from the South Shore, and I'm coming here to speaking from the perspective of the intersection of healthcare policy and criminal justice reform. I'm a criminal justice reform activist. I'm a board member of Families for Justice's Healing, on the steering committee of End Mass Incarceration Together, a member of the UCC Restorative Justice Task Force, and a volunteer for the Mass Bail Fund. So I'm representing myself rather than these organizations. A couple of years ago, I was on vacation in Cape Breton, and I was at an Airbnb run by a retired nurse. And I was talking about my activism, and she said to me, "You know, Llewellyn, societies that really care about their population, that really care about their people, who provide good health care, affordable housing, opportunities for education and job training, there's very little crime or incarceration to begin with." And we kind of all know that, but we don't remember it. So I want to talk very specifically about health care. About half of the people who are incarcerated in Massachusetts are diagnosed with a mental health problem, and about 70% have a history of substance use disorder. People with these health issues, as they're incarcerated, they get very inadequate, inconsistent care. And not only that, the very act of being incarcerated exacerbates people's health problems. So clearly, we want to address health issues for marginalized populations in the community, not inside prisons and houses of correction. In Massachusetts, we only recently, medical schools have really taken seriously the business of teaching doctors to be about addiction. So the young doctors are coming up learning about this. And there's a lot of promise now for integrating addiction care with primary care. But the financial barriers remain. With our fragmented healthcare system, with its high deductibles and inadequate coverage, it doesn't lend itself to people getting the care they need. A Medicare for All system financed through our taxes with the cost savings of eliminating premiums, deductibles, and copays will encourage people to get the care that they need. A Medicare for All system will not only better the lives of people who might otherwise end up in the criminal legal system, it will also enhance public safety, and this benefits all of us.
Thank you very much. Jen Wiseman, Gillian Mason? John, is it John Wiseman?
Hi.
It's a reunion. Yeah, sure. So my name's Jillian Mason. It's okay, people mispronounce it all the time. And I'm here to testify in favor of House 1194 and Senate 683. I apologize, I'm actually not feeling very well today, which is, ironic, right? So I am here as the executive director of Massachusetts Jobs with Justice, a coalition of over 160 different unions, community groups, student groups, and people of faith, all united to build working class power in the state of Massachusetts. We've long been supporters of single-payer health care. And, I personally became an advocate for single-payer health care after being sick for 5 years in my mid-20s and going broke after several hospitalizations. That's how I came to do activist work at all, actually. And I know that single-payer activists are known for being naive, or perceived as naive, but actually a lot of us come to this work from being sick, and being sick has a certain kind of wisdom that it gives you. And so a couple of the really lessons that I learned from being sick were don't be a student, because in Massachusetts, student health care actually allows for-profit companies to come in. I was a grad student when I got sick and had a terrible experience. Never take an ambulance, right? Even if you're going to lose consciousness in the back of the taxi cab, you still can't afford the ambulance, and you'll probably make it to the emergency room on time. Ask your doctor what drugs he has samples of in his office, because those are probably the drugs that you're going to be able to take. I had one doctor who gave me drugs that were really not proven, as opposed to a reliable drug that had been tested for 10 years, because those were the ones that the pharmacy rep had dropped off at his office, and he knew I wasn't going to be able to afford them anyway. When you go to the hospital, don't ask how long you should stay. Ask how long will they pay, because there's often a different answer, and you'll get a different answer from the doctor and from the insurance company. And then this is finally a lesson that I got from a former friend of mine. She told me, she was a banker, she told me, if you have lousy health care, it's capitalism's way of telling you that your job isn't important. Now, that's a really thing to say, pardon my language, right? But the truth is that really articulates, I appreciated her candor, because that really articulates what our current system says to people like me every day. Now, at the time, I was a college professor. I felt like my job was worthwhile. But I want to stress that I am a middle-class white lady, right? And my experience with the healthcare system has been this terrible and this traumatic, right? At Jobs with Justice, we meet people every day on the worst day of their lives. No one comes to see us because they're really thrilled with the way things are going. We have people coming in every day to talk about who are struggling with his healthcare issues, people of color, homeless people, people in low-income jobs and hourly jobs, people who are having such a terrible time doing this. We have people whose employers schedule them for fewer hours every week so that they don't have to provide them health care. We have people come in who are being held hostage in bad jobs because they need the health care. I spoke to a woman a month ago who told me that her boss was sexually harassing her, but that she needed to stay in the job because that's where her health care was. We have people who put off therapy for one more day because they can't afford the copay, and God only knows if that next day is going to come for them. We have undocumented factory workers who have really given their entire lives, worked their fingers to the bone, worked to the point where their bodies are twisted and desperately in need of care, who will never be able to access the system that they've paid into all of these years. All of these people need this desperately. And I know what you're going to say. You're going to say it's complicated. You're going to say it's difficult. Well, guess what? It's complicated and it's difficult for all of these people, and not all the complications of this system should fall on them. The complication of figuring out how we switch to single payer is a moral issue, and it's something that needs to fall on legislators like yourselves. So I really appreciate the fact that you're willing to take this issue up. I hope that you will further the conversation by reporting it favorably out of committee and letting us have a full discussion on the Commonwealth about what we really need for healthcare here. Thank you.
Hello, my name is John Weissman. You'll get the correct spelling in my written statement. It's been submitted through Representative Sabadosa. I live in Granby, another one of those conservative towns that has voted for single payer overwhelmingly, 2-1. I'm the co-convener of Western Mass Medicare for All in retirement, and I am also on the board of MassCare, the Massachusetts campaign for single payer health care. I'm in my 50th year in the labor movement. At least half of that time has been spent advocating for single payer. And during that time, in and out of working with MassCare, we have created the two bills that are before you with identical language to create the healthcare trust. That's your touchstone, that's your model, that's the plan, that's to do the job. It's one of the best bills in the country in the state movement for single-payer health plans. And in that time, what we've learned in the labor movement is that the urgency couldn't be worse. It's a complete devolution at the bargaining table of what it takes to carry out the old-fashioned bargaining over health plan, job lock health plan. So let's get rid of it. What we're in a climate now is concessionary bargaining. Every bargaining table is faced with a downward spiral. That's leading to strikes and disruption of the economy that we can eliminate with the single-payer plan. These strikes have been sometimes very bitter, and the result has not always been, like Stop and Shop may have been able to preserve their plan, one more contract, as we just saw, but the overall devolution can be stopped by taking this off the bargaining table. Health plan bargaining in the labor movement is a battlefield. Battlefields cost time and resources, and in this situation, lives. We don't have time for a 5-year study. We don't have time for another commission. Our bill has been studied by the legislature in prior sessions. Our bill has been studied by Jerry Friedman at the University of Massachusetts. He helped write it. You can be confident that this bill is not only establishing the right to health care in Massachusetts, in the Commonwealth of Massachusetts, it is also going to do what you expected to do to save money and lives. Thank you.
Thank you. Devin Grayson.
Thank you. My name is Devin Grayson, and I'm a dual U.S.-Canadian citizen. I wanted to talk to you a bit about that experience. After growing up in the USA with a physician father and excellent health care that I never had to think about, over the past 15 years, my career and education have brought me to Canada, and then this past year back here again. And I've learned a great deal about healthcare systems in the process. When I left the USA 15 years ago, healthcare was a chronic stressor. I was the director of a small nonprofit, and providing benefits for our few full-time employees it just put a constantly increasing strain on our organization's budget as each new insurance contract cost our business more, provided less coverage, and required higher deductibles for our employees. I then went to Canada for grad school, and I became quite ill shortly after moving, actually. And it took a while to figure out what was wrong and to fix it. And I will always be grateful that I moved to Canada at that time in my life, because my costs were incredibly manageable during that scary period. Mainly prescription drug copays and a few hospital parking lots. Canadian Medicare is far from perfect. However, moving back to the USA has caused me renewed appreciation for the things that Canada and every other affluent country in the world has figured out. The inefficiencies of the current system here have been staggering to realize, and my family has barely accessed health care since moving back, only routine and preventative care for a healthy family. We are lucky. I know we're lucky, but hoping to continue being lucky is no way to live. And leaving behind all of our friends, neighbors, and colleagues who aren't so lucky isn't an option in my eyes. Here are some questions I get asked a lot by Americans about Canadian healthcare. Can you choose your doctor? Is healthcare rationed? What about wait lists? And are the taxes really high? So for the first, I have to ask, can you choose your own doctor? Because I couldn't when I moved back here. When I moved to Canada, when I got sick, I just went to the clinic near my house, and when I saw a doctor I liked there, I asked him if I could become his patient, and I did for the next 14 years that I lived there. Here, it's been a nightmare negotiating ever-changing lists of in-network providers and preferred providers and providers that are not in the network anymore after December 31st. To the second issue of rationing, I also have to turn around and ask, isn't your healthcare rationed here in the US? All healthcare is rationed. But the difference is that in Canada, my province had a public committee that weighed the evidence of every new treatment and decided whether it was worth covering for everyone who needed it. And in the USA, my insurance company makes these decisions privately behind closed doors in a multi-tiered, obscure system that benefits those with the most privilege. To the third about wait lists, I say, yes, there are wait lists in Canada. I have waited for things, and I'm fine with that. I'm fine with the waits that I have done because it's done in order to prioritize urgent and emergency care. And sure, it would be nice not to have to wait ever, but in situations where there's not enough of something to go around, I would rather wait like everyone else than let the wealthy jump queue while the poor never get access. And to the final question, that of taxes, I have to be honest here. In my middle-class experience, taxes are the same percent out of my paycheck here as they are in Canada. But the difference is if I add up my taxes and all the other money that I spend on healthcare, I pay so very much more here in the USA than I ever did in Canada, because the US healthcare costs are double those of what any other industrialized nation pays. Having experienced both the Canadian and US healthcare systems, while neither is perfect, one of them protects residents from medical bankruptcy. One of them provides greater efficiency and much lower costs to individuals and employers. And one of them has substantially lower infant maternal mortality rates and longer life expectancies, including for those living with serious chronic illness such as cystic fibrosis, 10-year longer life expectancy in Canada than in the US. But both can if we take action here. Canadian Medicare started in one province, Saskatchewan, and it was so successful the whole country wanted it. And as happened with the Affordable Care Act, Massachusetts can again be a national leader in providing a template for healthcare improvements for the entire country. Universal health coverage is hands down one of the most important US policy issues of our time. Freed from the stress, finance, and illness burdens of the current system, the American public can live longer, less fearful, and more equitable lives.
Thank you.
Thank you.
Have you submitted that testimony?
No, but I would be happy to.
Oh, would you please?
Yes.
Thank you.
And if you have any questions about Canada, I'm your Canadian.
We'll know to call. That was very informative. Thank you. Dialia Stelly? Sty? Sty. Is that Diana? Oh, sorry. I think the pen was running out.
Thank you to the Joint Committee on Healthcare Financing for having this hearing. It's really important, and I'm glad you're doing it. I'm here to advocate on behalf of the Senate Bill 683 and the House Bill 1194. I awoke in severe pain, excruciating pain, a couple of years ago, and finally decided at 2 in the morning to go to the local hospital because I just couldn't stand it anymore. I was taken home immediately. One advantage of going to the ER at 2 in the morning is there aren't very many people there, and put in a bed and told that I needed to stay for observation, so they were going to put me in a hospital bed. I was worried about this because I had heard that there are 2 different ways to get a room, 2 different statuses, if you will, that a patient in a hospital bed can have. One is to come in through the ER and stay for 1 or 2 days, in which case your insurance company doesn't cover it. Now, I should tell you, I have excellent insurance. I have Medicare and GIC, the state plan. So I was shocked to find this out. If you come in for a planned event, then you come in and you're not subject to that, although there is still a 3-day rule. Our system is nutty. We should not have to worry when we're in excruciating pain whether our stay is going to be covered when we have health care insurance. Nonetheless, as it turned out, I was seriously ill and I had to stay for 5 days, and they did cure me, which I'm grateful for, and I did not have to pay. But that's an example of one of the idiosyncrasies of our system, that the billing is not straightforward. And when people talk about comparing costs before you have a procedure, they're not taking emergencies into account or any way to even find out what's covered and what isn't. Another experience we had was during the wonderful year we had in England. My son was 5. He had severe abdominal pain, and his physician said he had to go to the hospital. We went. It looked a little old-fashioned to me, but it was very child-friendly. The doctors examined him while he sat on the floor, so he was feeling, playing with toys. He felt very comfortable and not scared. He was there, had supper, fell asleep. They put me in a room so that I could be there in case he woke up at night, so this would not be a traumatic experience for him. And the next day, we went home. We paid $0. And I was so impressed with the care, and that's one of the reasons why I fight so hard for single-payer care, and I do hope you will let this bill come out of committee.
Thank you very much. Barbara Pearson? Go ahead, you go forward, I'll go backward.
Yes, my name is Barbara Pearson. I'm from Amherst, and I'm here in favor of the 1194 and the other. And I'm actually kind of still stuck on the hearing you all had in April on the drug pricing. And I'm glad Devin mentioned cystic fibrosis because, you know, I read in the Globe, the Biotech Council exec really convinced everybody that all these incredibly expensive drugs are the price we pay for, one, having a thriving biotech industry, and two, that's how we can save people and improve our care for a disease like cystic fibrosis. So I'm thinking, this doesn't fit with everything I've learned about healthcare over the years that I'm doing it. Is this, in fact, the case? And, you know, maybe we have to revise what we're thinking. So I did a little research, because I'm a researcher, and it turns out that the drug that they were talking about costs $300,000 a year. So if you can picture the GoFundMe campaign for the first year, I don't know that you could do it the second year, but it's the kind of thing that you take every year of your life, okay? But it turns out that cystic fibrosis is a perfect example of a profit-driven attitude toward how to improve healthcare and a equitable Medicare for all one. So as Devin said, they have the highest, Canada has the highest life expectancy for cystic fibrosis sufferers. The U.S. has increased since 2000. It was 30 years, now it's up to 40 years. It may continue to grow. And when you try and find out, okay, what's the difference? Well, they get a few more transplants, lung transplants than the U.S., 10 to 6%. But they're not putting their money on the silver bullet, hugely expensive drug. They're putting their money on care, consistent, available care that you can have in this kind of, it's a terrible disease. It's always, you always need the care, and you have frequent crises even when you're doing the care. And so that's what's very, very hard to get in the United States is chronic care support. So there are some diet things. There's a big diet thing, and Devin actually thinks that the U.S. is going to do better now that they've adopted the diet. And this miracle drug, it turns out, well, I'm not against research. I mean, I've been a university researcher for most of my life, but the drug that costs $300,000 and is approved as a breakthrough drug, it turns out the genotype for that drug, 4% of cystic fibrosis people. So the Cystic Fibrosis Foundation and the researchers in Boston are trying really hard to put together more expensive drugs to make a cocktail that'll fit other people. Anyway, the bottom line is that cystic fibrosis is a great example for exactly the opposite. So it's a great example for consistent, equitable care that they use it for the 4%. In Canada, they use that drug for the 4%. But basically, I don't think we have to be, based on that, I don't think we need to be held hostage to the incredible profit-driven things. Anyway, thank you very much.
Thank you very much. Christopher Martin.
Good afternoon. My name is Christopher Martin. I represent the Holyoke Hub of Western Mass Medicare for All, as well as I'm also a co-chair of the Health Justice Working Group of the Democratic Socialists of America's Pioneer Valley chapter. I'm a resident of East Hampton. And today I'll be speaking in support of House Bill 1194 and Senate Bill 683. And I will be recounting my personal experiences with access and affordability to health care and what this led me to believe. I, like many of my generation, have been trained to accept a large amount of debt early on in life to afford schooling. This awareness of debt is powerful, and it shaped my imagination as to what I could do with my life. I wanted to be considerate and realistic, so I got a professional writing degree at UMass and became a tech writer. I got a decent job out of school to cover my repayment and worked that job for 2 years, building up decent savings accounts in the process. Then I was laid off. But to my fortune, I was in the process of being recruited elsewhere and only lost a week's worth of income in the transition between jobs. A week after starting work at this new job, I was just riding my bicycle to my friend's house. I flipped over the handlebars and broke my neck and received a severe concussion in the process. But again, to my fortune, not only did I survive the accident, obviously, without any permanent or sustained damage, but also my new job had no waiting period before I could begin using their healthcare plan. And I was able to get the care I needed. But yet, despite all this good fortune, because the new plan was a health savings account, I had to pay all of my bills directly and promptly cough up $2,000 deductible before my insurance would begin to cover any of those bills. This experience taught me two things: how a freak accident could bring tens of thousands of dollars of debt in a moment, and how beyond the potential debilitations of this accident, you're also only one moment away from being in a deep, essentially bottomless hole of debt on top of whatever other financial burden you may have been experiencing. Despite being insured, the time I had to take off of work on top of my deductible destroyed what meager savings I had acquired, and all that is with me still considering myself fortunate for being employed when it happens. This made me realize just how precarious the daily life of Americans are, regardless of whether they currently fit within a government plan or are covered through their employers. And I recognized this anxiety in others around me as I began to work as an activist organizing for a universal health care plan. I had conversations with hundreds of citizens while collecting signatures and canvassing for this cause. And not only did I receive near universal enthusiastic support for the program, I also learned all the ways that our current system has failed the residents of our state. How means-tested plans kept them from getting a better job due to having a better coverage under mass care. How residents held off on retiring because they couldn't afford drug prices and care under our current Medicare system. And how a sudden job loss left families reeling not only from their loss of income, but knowing that a single stroke of fate could doom them out of any hope of a stable, middle-class life that has been the foundation of American aspirations for nearly a century. They deserve this burden lifted from their shoulders. They deserve a simple and clear guarantee that they will be cared for in their times of injury and illness, and they deserve health care to be recognized as a human right.
Thank you.
Thank you.
If we need to leave this room at 3 o'clock, so I'm going to have to keep people very tightly to the schedule so that we can finish on time and everybody gets a chance. So I apologize ahead of time for interrupting you. Michael Barboza McLean.
Thank you for allowing me to speak. I'd like to give a couple of personal anecdotes on why I support Medicare for All legislation. Our current private health care system is unable to have adequate care and affordable care for people with mental illness like myself. Diagnosed with bipolar disorder at age 16, the severity of my illness at times resulted in hospitalizations and ambulance rides for suicidal ideation. As I received these necessary services, it put a financial strain on my mother. One 30-minute ambulance ride costed her $1,000 in out-of-pocket costs, and several hundred more for my hospitalizations. The strain this put on my mother led me to think that I was a burden to her. I decided against seeking help in my darkest moments because I did not want to bury my mother in further medical bills. I was hospitalized recently for a suicide attempt, and many of my fellow patients had the same anxiety. They were anxious about if they could afford to pay for their stay. This system is part of the illness. It causes these seeking treatment for their mental illness to be afraid about overburdening hospital costs, leading to further and unneeded stress in their struggle to stay mentally well. Our healthcare system also allows for ever-increasing copays for medication and for crucial services such as therapy. At times, my mom struggled to pay the nearly $100 copay for my medication. Additionally, I recall the crisis I had while I was away at college. I couldn't afford the now increased $150 copay for my meds that kept my bipolar disorder in check. This led me to ration my medication, and eventually I was left off my meds for 2 days. My mental state deteriorated so much that even when I afforded my meds, I was so unstable that I used them in an attempt to kill myself. My copays for crucial services like therapy ballooned from $15 to $45. It became so bad that I needed to switch to Mass Health to alleviate my mom from this burden. I am lucky to be on Mass Health, but being lucky to have a good health care plan shouldn't be something I need to say. Everyone should have access to a health care plan with comprehensive coverage and with little to no copays or deductibles. There shouldn't be any stress of thinking how one will afford life-saving services. Like the rest of the industrialized world doesn't have to think about that. My healthcare costs aren't the only instance of financial stress due to medical costs in my family. In 2015, my family was blindsided when my grandfather was diagnosed with terminal cancer. It was a short battle that left my family emotionally scarred and my grandmother drowning in so much medical debt that she needed to declare bankruptcy. Bankruptcy from medical debt is a purely American reality that results from our expensive and inefficient healthcare system. As me and my grandfather's stories have shown, all of these instances of financial stress could have been avoided with a single-payer healthcare system. So I don't need to ration my medications. So I didn't need to feel like a burden to my mother. So people with similar afflictions can focus on getting better and not worrying how they will pay for these services that allow them to mentally heal. And so grieving families are not left with mountains of debt when their loved ones passed from a serious illness like cancer. Thank you.
Thank you. And thank you for sharing your story. Marcia Plant-Jackson. Okay. David Perlman. John Ratliff.
Thank you to the chairs and members of the committee for this opportunity to testify. I'm representing Massachusetts Senior Action Council, which is an organization you're probably familiar with, advocating for the rights of older members of our Commonwealth. And we want to express our strong support for the improved Medicare for All proposal that is contained in H 1194 and S 683. I would emphasize the improved part of it because even those of us who have reached the stage of our current Medicare see that there are many problems in the healthcare system that I think spill into Medicare as it is today from the inadequacies of the rest of the system. And I want to thank you guys for helping us address at least one of them in your budget proposals, which would expand the Medicare savings plans eligibility so that low-income seniors don't have so many costs in obtaining the health care under our current Medicare system. But you know, it's kind of these reforms are really important for Massachusetts seniors as well as all of those who aren't part of our current Medicare system. By the time people make it through this broken, fractured, expensive, and unfair healthcare system to reach the age of 65 and finally get Medicare, which at least points in the direction of where this bill would take us, they're coming there with all of the results in their bodies and their health, their own biological systems of inadequate treatments, postponed care, all of the things that you've heard about from people who have suffered our current system. And that increases the cost of the Medicare system, which already focuses on those of us whose bodies are old and have been through a lot in our working lives to get to the place where we can do it. So it expands and puts us all in the same pool for health care costs. And it puts our teeth, which are just as old as we are, and our ears, which is just as old as the rest of our body, and our eyes in the same system. So it is a dramatic improvement that will benefit every single person in our Commonwealth. So I really encourage you to report it favorably, and on behalf of all of our members from all over the state, would encourage that the House and the Senate eventually pass these two important bills. Thank you.
Thank you very much. Alan Myers.
Good afternoon. My name is Alan Myers. I'm a Cambridge resident, a retired pediatrician, and emeritus professor of pediatrics at the Boston University School of Medicine. I'm also a founding member of Physicians for a National Health Program, a member of the Right Care Alliance, and I'm on the board of Mass Care. I come to speak in support of Medicare for All because our system of healthcare financing is broken. U.S. per capita health expenditures are twice the average of other developed nations, and in Massachusetts, we are second only to Alaska among the 50 states. Yet we in the U.S. are far behind in health status, with the highest infant mortality and the lowest life expectancy at 60 among comparable developed nations. While 97% of Massachusetts residents have some form of health insurance, more than any other state, for many their coverage presents serious financial challenges. Nationally, 28% of non-elderly adults with health insurance are underinsured, meaning they spend 10% or more of their income on out-of-pocket medical costs, not counting premiums. Half of those with employer-based health insurance reported that someone in their household skipped or postponed needed care due to cost. Nationally, 41% of those covered by employer-based health insurance are in high-deductible plans, and amongst those, 44% have savings less than the amount of their deductible, which for a family plan averaged $4,527 in 2017. And when people are faced with high deductibles, they stay away from care. A recent study found that women diagnosed with breast cancer delayed their care when switched to a high-deductible plan, the consequences of which could be devastating. Do we think that access to health care is a basic human right? If so, it must be guaranteed by the state. The legislation you are considering would ensure that all Massachusetts residents enjoy this basic human right, ready access to comprehensive care without financial barriers, and specifically with no out-of-pocket cost to the patient. Virtually every other wealthy nation provides such guaranteed access to care. Canada, with a single-payer system, spends about half what we spend on health care, and about half of that difference is accounted for by the dramatically lower costs of administering this simplified system compared to the bird's nest of complexity presented by the myriad plans from multiple private insurers that change constantly here in the U.S. And health outcomes in Canada are, in many cases, better than our own. In the U.S., young adults with diabetes are twice as likely to be hospitalized with ketoacidosis as are those in Canada. And people with cystic fibrosis who are highly dependent on medical care live 12 years longer in Canada. Do we need private health insurance companies? I would argue emphatically that we do not. Private health insurers add nothing to care but confusion and headache and profits for their shareholders. It is not possible to serve two masters. The bottom line for a healthcare system will either be the best possible outcome for the patient or the maximizing of profit for investors. It cannot be both.
Excuse me, sir,
Canada's
I'm gonna have
single-payer
to-
system
I'm gonna-
began in one province, Saskatchewan. We in Massachusetts could blaze such a trail for the United States. Thank you.
Thank you very much. Okay, Ron Peartree. Peacetree, sorry.
Good afternoon, honorables. My name is Ron Peacetree. I'm a resident of Haverhill, Massachusetts, and I'm going to be the least touchy-feely person that you guys talk to all afternoon. I am a physicist and electrical computer engineer, the first member of my family to attend university. I came from a family that was dead broke, 7 people, $7,000 a year, and I became CTO at 2 companies and helped 6 not go broke. And I'm going to tell you I'm in favor of this bill because the economics are favorable. For 40 years, I've been in this industry, and when I first started, healthcare was a small percentage of the overhead of a business. It has now become so onerous that business plans don't get okayed because of the costs, because we can't afford it. We've got people who are making decisions, as all of these people have talked about, that are not in their best interest because they're so desperate to keep their health care. Your jobs and your peers' jobs is made more difficult by the secondary and tertiary effects of the outrageous, out-of-control healthcare costs. In the 40 years I've been in business, on average, every year, no matter what the economy is doing, going up, going down, staying the same, healthcare costs have gone up between 3 times and 5 times, with spikes of 7 times faster than inflation, no matter what. That's a system that's broken, and it's not a partisan political issue at that point. We've got to get it under control. Every other member of the G20 has half the healthcare costs we do per capita, as the doctor just mentioned. We know why. Lack of controls over pharmaceuticals, lack of controls and transparency over standard procedures and equipment. There's a whole slew of things, best practices that we know we could implement and we could put in place. And yes, there are some people who have been a little bit too greedy and they need to be dealt with. But right now, the big issue is whether you're talking about criminal justice, you're talking about economics, or you're talking about education, there are ripple effects from this that are completely distorting the way we do everything. And if we don't control this beast, we're spending more money on this now than some parts of the military. It's ridiculous. Thank you.
Thank you. That concludes the list of people who've signed up to testify. I want to thank everyone for your patience, and for those of you who stuck it out through the long haul. Thank you, and I thank you, the committee members. Is there a motion to adjourn? All those in favor? We're adjourned.